Very good evening to everyone. Very good evening to everyone. Warm greeting and welcome from course 5D PCI Exotica. Dear guests physically presented to me here today as well as my virtual audience today, I am Dr. Shivakumar from Meenakshi Mission Hospital from Madurai, the Temple City of India, taking great pleasure to welcome you all to an academic feast, 3D's third edition called as course 5D PCI Exotica. Basically, we coined this course by anything in coronary, whether it is bifurcation or calcium or ISR, we need to define the problem, then we need to design the strategy, then we need to deliver the PCI in a way it should be predictable as well as it should be as less maze-free outcome. How we can do this? By demonstration of live cases and of course by discussing real-world coronaries. That's how this word came in course 5D PCI. Over the course of next 3 days, we shall be enlightened with discussions pertaining to various aspects in the entire coronary spectrum, with a special focus on imaging and physiology, with the keynote lectures and debates from distinguished faculties, an in-depth and comprehensive interventional cardiology virtual meeting involving national and international key opinion leaders. After a successful first edition of 3D in February 21, in the peak of the pandemic, where it was just defined design and a strategy, then we went ahead in September 21 with the 4D, added on to the 3D, we added debates and discussions, and this course, which is a hybrid, physical as well as virtual, we made it as 5D by demonstration of live cases as well as discussing real-world coronaries. With the support extended and warmth provided, this has motivated to me prepare and presented to you the recent updates in the field of interventional cardiology. With the day 1 and day 2, we have 2 sessions. In day 3, being a long day on Sunday from morning 10 to 5 p.m., we have 5 sessions. We have 8 live cases in and around the city, and 4 live-in boxes from young cardiologists, recorded live cases will be transmitted. And we have 3 international faculties and 12 national faculties. We are happy to host and bring you to the learnings, over 200 minutes of learnings every day. And without much delay, I welcome you all for the day 1 course of the 5D PCI Exotica. To start my session 1, which is comprising of basically live cases back to back from Government Rajaji Hospital as well as from St. Joseph Hospital, Dindigul, for which the chair is our respected Dr. Madhavan from Madurai. Please come to the dais, sir. And panelists, my colleague from MHRC, Dr. Ganesan. Dr. Ganesan, please. And Dr. Karupaya is expected soon to join us. And in between the 2 live cases, we are expecting Dr. Ashok Sheth to come up with his keynote lecture on how to deal with calcium in real world. And regarding the live cases, the first live case is from St. Joseph Hospital, where the in-house cardiologist, Dr. Anand, will be doing the case along with Dr. Deepak Davidson, our great friend from Kerala. And in the second live case from Government Rajaji Hospital, under the leadership of Dr. Balasubramanian, the professor of cardiology, the team, R.R. Saravanan and Satish will be doing along with a proctor from Chennai, Dr. Damodar. I request the chair to go ahead with the session and let's have the live cases, and in between the lectures, in between the 2 live cases, let's have the lecture from Dr. Seth. Over to chair.
Good evening, everybody. Thank you. First of all, let me thank Dr. Shiva, the course director, to give opportunity to me to chair this session. Without wasting much time, we will welcome St. Joseph team, Dr. Deepak and Dr. Anand. Dr. Deepak, Dr. Anand. Good evening.
Yeah, hello.
Good evening. This
Good evening,
is Dr.
sir.
Madhavan. With me, Dr. Ganeshan, Dr. Shivakumar.
Hello, can you see us?
Yes, very much.
Can you hear us also?
You are as well.
Good evening to all of you.
Good evening. Good
Well,
evening.
well, it's great pleasure for us to be with you today evening. I am Dr. Deepak Davidson. Along with me, Dr. Anand. We are right now at St. Joseph's Hospital, Dindigul. We are planning to have intervention in a calcific left anterior-descending artery. Before we start off, I give the opportunity for Anand to introduce the team as well as to introduce the case. Please
Go ahead, Anand.
Thank you, Madhavan sir, chairpersons. I'm very thankful to Dr. Deepak Davidson sir for accepting this invitation to come to our hospital. And I thank Dr. Sivakumar sir, About team, and all the panel members involved for giving us this wonderful opportunity to have our center, our hospital as one of the centers for live case demonstration. Along with me, we have our team of St. Joseph Cath Lab staff and assistant technicians. So we have anesthetist ma'am. So we have Maridanayagam, Louis sister, Pandi, our Cath Lab technician, Madhu, and Celia, sister Jay Celia. And they are the pillars of our department, actually, without whom we can't do any work. And we have Dr. Madhumalar, who's been very helpful because most of our cases are emergency cases, and irrespective of the time of the day, she comes for all the emergencies. And shall we go ahead with the
yes,
case?
Yes.
So,
can you show the fluoro monitor? Okay, today's first image. Please.
Yes, sir.
Today's first image. Okay.
So first, the clinical presentation of our patient is, he's a 70 years gentleman. He had an acute infraposterior wall MI in Jan of this year, and he underwent primary PCI to RCA, and then he recovered. His coronary recovery was uneventful, but then he contracted COVID-19, and then he has a turbulent recovery for his pulmonary component. And then during his first presentation with acute coronary syndrome, we found that he had critical double vessel disease. So the right was addressed immediately, and his left system showed a very long segment anterior descending, left anterior descending artery segment stenosis, calcified lesion, and circumflex was mildly diseased. So we fixed the right, and now we are planning to fix his left system. So
can you show the next image?
So this is his angiogram, caudal views first. Okay, so this is his angiogram. It shows disease in the distal left main and osteoproximal LAD. The entire segment is calcified, and we can see there is mild diffuse disease in the circumflex, but there is no significant obstructive disease which is noted angiographically. Next image.
Yes, explain the
Next.
CAT.
So here we can see there is a long segment disease in the proximal to mid segment of LAD, and it is quite calcified. And so we proceeded with intervention. So we used run-through wire along with microcatheter support, and we crossed it with crossing was pretty simple. And after that, we introduced a rotofloppy wire through microcatheter exchange.
Anand, can we intervene a minute?
Yeah,
Yes,
yeah, Shiva, one second. Our plan is the left main appears to be mildly diseased at the bifurcation. The circumflex is mildly diseased, but without any critical disease. And the LAD has got critical stenosis, which is significantly calcified. So our plan was to manage medically the circumflex, whatever mild disease it's got, and then to consider the proximal left LAD lesion as a very significantly calcific stenosis. It looks like tram track calcification, looks more of subintimal. So we thought that we'll start off with a 7 French guide catheter, do a rotablation to the proximal left anterior descending artery, then do an imaging, evaluate the left main, LAD with OCT, and then further proceed. That's what we have decided. Kindly we invite your suggestions.
What made you to go ahead with the upfront rota? Was any initial attempt with the balloon crossability was tested, or how you made the decision of upfront rota?
Shiva, can you previous run? Okay. Previous run. Okay, now in this cranial image, if you could concentrate before we inject the contrast, you could see that the left main bifurcation has got almost an eccentric calcification, that is on the base of, in this view, you could see that on the base there is some calcification. As you look at the proximal left anti-descending artery, before we inject the contrast, you could see that there is significant amount of calcification on either sides of the vessel. To start with, it looks more of adventitial. As we come more downwards in the LAD, it looks as if it's a wire hugging. That is, it's more of a subintimal. It looks like a more of subintimal, which appears to be on either sides. So that was the reason why we decided that. Moreover, it's a more than 90% critical stenosis. So that's the reason we decided that we'll go up front within 1.5 bar, do a rotablation, then go ahead with exchange the wire and go ahead with an imaging study.
So you mean to say angiographically severe calcium. What was the tactile feel when you were trying to cross the wire? Was it feeling like hitting a rock? Was that kind of information you get it?
Yes, sir. So there was the wire crossing was easy, but there was a rough feeling. So it was hitting a lot of calcium and fibrous tissue.
Perfect. Go ahead. How you set up? So now we are convinced reasonably that from angiographically and from the tactile feel, of course, it would have been a futile exercise crossing a balloon and getting that feel, as we are obviously seeing either side of the coronary sill out, we are seeing the calcium, and there is definitely a visible luminal calcium, and we agree that you also had the tactile feel. So how your judgment of, so now this is upfront rota being without imaging help, how you size the burr?
Okay, Shiva, now many times, okay, before that, the distal vessel was looking too small and tortuous. So we decided that we wouldn't do a primary wiring with a rotafloppy. We almost always take a workhorse wire. Here the workhorse wire is a run-through wire. We went ahead with a run-through wire. It was not too difficult to go across. Then subsequently we took the micro catheter, which was a bit difficult. It was a fine cross catheter. It went across. It was positioned distally. Then we went ahead with a rotafloppy. Now once the rotafloppy was there, many times in a proximal LAD, we know that it's a big vessel. It's at least a 3 millimeter vessel. So we almost always prefer going with an 1.5 millimeter burr. Many times we try avoiding 1.25 millimeter burr, primarily because 1.25, the chance of trapping distally is little bit more compared to the other bigger burrs. And second problem is the amount of cuts that you have with an 1.25 burr is significantly less. So there are certain situations wherein we would straight away prefer an 1.25 burr. If it's a very tortuous vessel, if it's an extremely eccentric calcification, these are two situations wherein we would go up front with an 1.25 millimeter burr. Otherwise, it's almost always 1.5 millimeter burr. And the third situation wherein if the burr doesn't cross with an 1.5 millimeter burr, if there is a situation wherein it doesn't cross the lesion, that particular situation, again, we would downsize to 1.25. Otherwise, most of the situations, it's going to be an 1.5 millimeter burr. What's your thought on this?
Yeah, so it is based on your distal reference size. Is it something to do with your indented stent size, 50% of the indented stent size, or is it to the distal reference, or it is at the site of the calcium where you think the impediment is going to be maximum? You take a call on the burr size at that site of the maximum narrowing. Just provoking you to how generally people decide.
Yes, Shiva. Primarily, it's decided based on two important things. One, the vessel size. Here, the vessel size doesn't look real. It's a diffusely diseased vessel. It looks 2.75 to 3. Even the proximal LAD looks less than 3. So probably 50 to 60%, it would come to 1.5 millimeter burr. And second most important thing is how tight the lesion is. Here, we felt that it's a very critical narrowing. Moreover, it looks as if you see, are you able to see the fluoro screen there?
Yeah, absolutely.
Okay, now you could see here that as we are trying to burr, the wire is actually, the calcium on either sides is actually hugging on to the wire. So it's very close to the wire, which means that it's a significantly intimal calcification. It's a superficial calcification. So, so we know that a 3 millimeter vessel, you need to have a proper cutting. To start with, an 1.5 would be reasonable. Many times we wouldn't upsize it. Unless and until the balloon doesn't open it, we wouldn't upsize it. We would downsize it only if the 1.5 burr doesn't go through.
Right, perfect, Davidson. You just finish your rota part. We'll just go to the GH and come back to you again. Before getting into your imaging, just tell us
Yeah,
what feel
yeah,
you had with the burr. Yeah.
can we just make one more point before you move on to GH?
Yeah, please, go ahead.
Yeah, show this image. So this is the first run of 15 seconds. First run of 15 seconds at 180,000 RPM. You could see clearly that it's hitting exactly at that particular area, where proximally you could see that it's more of tram track on either sides of the wire you're seeing. But the area where you could see that burr is hitting, it's almost that particular area you could see that the calcium is tapering towards the wire that is inside the vessel. So that was the area where it was getting stuck. The first run of 15 seconds, it didn't go through at 180,000 RPM. Next run. So then that's the next run.
Yeah, we could see a nice pecking movement from you.
Yeah.
You were not trying to cross the calcium. You are just hitting, coming back, allowing the burr to do the job rather than pushing the burr.
Also,
Yeah.
we are able to make out the calcification seems to be less after the rota. Deepak, would you do bias in these cases, wire bias?
Sir, we do not have, we could pull the wire halfway through so that it comes to the more inner curvature of the vessel. We could push it distally so that it moves towards the outer curvature of the vessel. Here, the challenge here was you could see distally there is a significant tortuosity and it's a tapered vessel. So because of that, we were not bold enough to pull back the wire to achieve a better wire bias. So we thought that we'll keep the wire exactly where it is and then do the rotablation.
Okay,
And
fine.
this is the run following after crossing the calcified segment. That's the run following the crossing the calcific segment. Now we are ready to get the burr backwards.
Yeah, post rota it appears that calcification is less. Calcification seems to be less. So I think your decision of taking the rota upfront is reasonable. Otherwise, I thought maybe why not use Oxford balloon, two balloon, and enter whether how easily you could negotiate. I think retrospectively your decision seems to be fine. Please go ahead.
Yeah, that segment is completely
Thank you so
shaved
much.
off.
We'll continue to do. Meanwhile.
Yeah. Meanwhile, shall we go and come back?
There is a question on the chat box, sir.
Yeah.
If somebody could take it.
Please.
This is from Dr. Matsukani from Mumbai. For 2 LAD and LCX, distally LCX or OM3 has some issue. I think it's more of a point.
Yeah, they have the operator has already mentioned that OM seems to be a diffused and small thing they wanted to manage medically.
Yeah. So we will just, Deepak and Anand, we will just go to the GH and probably the GH case, Dr. Karupaya and Ganesan can take the lead. Can you come to the GH?
Suresh, mute yourself. Right. We are now going live to GH. Yes.
Yes.
Good evening, Sadish.
Sir, good evening, sir.
Good evening. It's nice to see you all.
Can you hear us, sir?
Yeah, we
can you hear us?
Sadish, Sharon, and we can hear you and see you. Damodaran,
Sir,
good
thank
evening.
you. Thank you very much, sir, for giving me the great opportunity.
Yeah.
Sir, this is from Government Rajaji Hospital, Balasubramanian sir and our team. And I'm going to present the case directly. So this is a 15-year-old thin-built gentleman who has come from Sivasi side. He had a STEMI and he has presented to the peripheral hospital very late. Since he presented very late, he was not thrombolized and he take subjected to angiogram. The angiogram, so this is a ECG interval STEMI ECG. So this is the angiogram done at a peripheral hospital. You can see a long left main with the tapering distal part.
Can I discuss?
Oh, yeah. So be the cranial view. So RCA is normal. So you can see the collaterals.
Yeah.
You can see up to the proximal LAD.
Yeah.
Yeah. Then.
So good evening, Dr. Shiva here, Dr. Damodaran here.
Yeah, good evening.
Am I audible?
Yeah, we can hear you.
Yeah.
You can start.
What's
your plan?
Thanks for the opportunity. We are here in Madurai Cardiology Cath Lab, Madurai Medical College Cardiology Cath Lab, and the case was discussed by our colleague Dr. Satish. A very interesting one. Initially, the patient's clinical history was like he had a STEMI and was thrombolized, failed. So the angiography showed distal left main, calcified plaque, not critical, and there is a blunt stump. Initially, when we were looking at the ECG which was taken outside, I was also deceived that this is going to be a recent occlusion. So it is a cakewalk, and we can just image the left main because the left main was showing some disease there. The angiography which was taken outside a hospital. So we thought we can do a LM to LAD crossover stenting after an OCT to identify the distal left main plaque and optimize it. But when we did the angiography here, the left main plaque, there is a calcified plaque, but the disease was not so huge. So we thought, okay, the job is going to be very simple. We can just do a LAD ostial nailing so that we can do a ostial proximal stenting. But then only we realized it is not an acute STEMI. This was a old STEMI, and again the patient might have reinfarcted because when I put the wire, the regular cause wire, it didn't go, not even touch the proximal cap. Can you see the, show the cranial view? One can see the cranial view now. There is a small stump with a blunt stump there. There is some calcium there. So the regular wires like BMW wire and even the pilot wire didn't go through. And this is a very, very critical location in the sense the left main, which is after that the LAD is taking a acute angle, so that it is very difficult, and the LAD ostium is hardly 1 or 2 millimeter. So it is very difficult to keep the microcatheter in place with the help of a wire. If you take keep the microcatheter, if you take a stiffer wire, the microcatheter collapses into the LCX every time. So now that I have just keep the microcatheter, the proximal cap, which is very calcified, and when you look at the previous angiography, the RCA didn't show any good interventional collaterals. There is very, very faint grade 1 collaterals. So we can't use the retro approach also here. So only issue is we have to go through antigrade. So after looking at the calcified proximal cap, I thought we have to go with a stiffer wire. That's what we have done now. The current situation is like that with the microcatheter, I have taken a confidence wire and just penetrated the proximal cap. It just went into the proximal cap into the body of the CTO. Then we need to proceed further. Any comments on that?
We are welcoming, by the way, Dr. Ashok Seth, watching Damodar from Government Raj Hospital, Madurai, doing a CTO. We welcome Dr. Selvarani also. Dr. Ashok Seth, please. Yeah.
Good evening, sir.
Hello, good evening to you. Great to see you, the live demo.
Thank you so much, sir. It's a very disruptive case that we thought of taking as a ACS. Landed up in CTO, which is very calcified, without much collaterals from the retro also. Partial collateral. So we have just entered the proximal cap, kept that microcatheter, fine cross into the body. So I am going to de-escalate the wire. Any your thought process and guidance for us?
No. The only thing that we didn't, and I watched the case right from as you were discussing, I certainly didn't see your simultaneous injections,
yes, that's
both antegrade and retrograde.
Yes. So
It's really good.
yeah. In the meantime, Sir can go ahead with this talk so that we don't want to make him wait, and we can proceed further.
Before
Can you just show that injection?
Yeah.
So that we can understand the length.
The antegrade injection.
And the retrograde injection.
Yeah, the retrograde. Actually, we thought it was acute occlusion. We didn't take the retrograde approach. And now that we are realizing of the wire trackability, we want to go for the retrograde approach. He's taking the access from the left side for the retrograde approach.
No. In the diagnostic angiogram from the RCA, was there any feeding?
Can you show the diagnostic angiogram, which is taken outside elsewhere? Yeah.
So, Dr. Damodar, this is Dr. Madhavan. Your plan
Yes,
is to have a dual injection, then proceed escalation with wire. Am I right?
That is the most safer way of doing it. You are absolutely right. So, but at one point when the proximal cap yielded, I have some perception that we are in the right track. But if you wanted to be absolutely correct, we need to have a retrograde injection as a check to confirm the position of the wire. That is always mandatory. Yeah, you are right, sir.
Dr. Seth, I have a question for you. When you are approaching a CTO, moment you are convinced is a CTO, is you routinely take a dual injection or case to case you take a call on that?
No, I don't take a case to case. If it's clearly occluded, 100%, and I don't see, and if I see retrograde collaterals only filling the distal vessel, I would do, invariably 95% of the times, unless I was sure that it was so recent that it happened in front of me, like a primary, like a fact that you saw an ST elevation 4 days ago. Those are the only situations. Otherwise, I would definitely do take a sheath well in advance on the other side to be able to give a retrograde shot. I'll tell you, there are many reasons for that. They're not just the reason. The other aspect is that you may go into a side branch, you may go into a septal, you may go into a diagonal, you actually do not know how long the total occlusion is. You never know, even in a soft lesion, where the toughest point is. So there are a number of reasons why you fall into a situation like this.
I think that's a clear message from Dr. Seth that moment you are convinced that you are a CTO and a diagnostic angiogram, you are seeing some help from the feeder vessel. I think you need to platform your antegrade as well as your donor vessel so that at some point of time, if you want to retrograde or convert also, you are able to see definitely a nice vessel coming up.
Yeah.
Another advantage is that the CTO is tapered.
PTCA guide.
Yeah, PTCA guide.
JR guide.
And the Y connector.
You know, you may cross it and then you may go down what looks like a LED, but it's actually into a diagonal. And then you keep pushing the sharp wire into what is a diagonal till you realize that it's not going any further. When you do retrograde injections, those become absolutely clear that you are in the main vessel rather than in branches.
So as he is setting up his retrograde support and he is planning to change his wire choices, shall we invite Dr. Seth to go ahead with the presentation? Dr. Ashok Seth from Delhi doesn't need a great introduction here. He is a well-known interventional cardiologist, and we all learn from him. It's time to invite sir to go ahead with lecture on real-world challenges
Sarana, please
someone
mute.
deals
Sarana,
with the
mute,
calcium
please.
and solutions to it. Dr. Seth, please.
All labs, please keep yourselves muted
It's
till
truly
Dr.
wonderful
Seth
to be with
finishes.
you all. I must just say that I said yes primarily because I just like to spend time with you all. The amount of stuff all of you do is so good that it's just great to interact with you, also watch you, and I'm going to talk about this. I hope you can soon see my slides on a slide share. I didn't think I shared the slide, sorry. Did I actually share the slide? No. I'll just go to the share screen, get onto my slide, share it, and now get on to the presentation. Okay. So,
Sir, could we go to the slideshow, please? Perfect.
yes, so you can see that now.
Thank you,
So
sir.
I'll try to give you some tips around a lot of this. And I'll give you my thought processes as well as tips around certain aspects of calcified lesions. And I'm talking about heavily calcified lesions and real world heavily calcified lesions. And of course, we deal with that every day. You deal with it, I deal with it. And many of the cases that we get are actually failures at other centers or at less experienced centers, or should we say peripheral centers. And if we can't blame anybody for that. It's just that some of the interventionalists don't have all the array of the equipment. And of course, there are limitations at working at some of the smaller centers, including the tension which surrounds all this. Now, we just want to understand one, and that's not for anybody who's sitting there. It's just for so a lot of young gen interventional cardiologists are watching this. It's a mistake that we continue to make all the time, including myself. Once in 2-3 months, I still make this mistake, but I keep emphasizing it so that I don't make that mistake. Is do not implant a stent till the lesion is fully expanded. with a near optimal size NC balloon. I don't say optimal size NC balloon because you go up with an optimal size non-compliant balloon in a 3 millimeter vessel with a 3 millimeter balloon and inflate it to 20 atmospheres, you actually have dissections, not at the site of the lesion, but also on the site of the lesion. You then extend the length of the stent, you destroy your landing zone, and I never do that. The moment I decide what are my landing zones, I will actually respect my landing zones, because quite often you have diffuse disease segments, you have long segments, and you end up with longer stents into areas which are nowhere, which then take you to multiple lengths of stents. And therefore respect your landing zones, near optimal size, which is quarter size less, go up to 20 atmospheres, and that's what's most important, balloon and in two orthogonal projections. Once we follow that philosophy, we have a number of devices available to us. And even though this tries to compare the devices between the ultra high pressure balloons like OPN, rotational atherectomy, laser, IVL, and by the way, laser is fairly poor for heavily calcified lesions. It's a poor device. It's a good device for uncrossable lesions, thrombus, as well as instant restenosis, but poor for calcified lesions. So we actually have three tools available to us: rotational atherectomy, ultra high pressure balloons, IVL. I'm really disappointed as far as scoring and cutting balloons are concerned for heavily calcified lesions. I'm talking about real complex heavily calcified lesions, fine enough as an adjunctive therapy sometimes, and also good enough for mild to moderate calcification. But of these three devices, while we may say IVL is easy to use and requires less of a learning curve and has least complications, we must also remember that it's actually the most expensive. So we've got to actually understand how to employ this judiciously, because we've got patients to take care of, to give them the best outcomes, but the best outcomes have to come at the right cost as well. And that's what value-based medicine is all about. So while we know this very well for calcified lesions, both the OCT criteria as well as the IVUS criteria now, we must also understand that these are retrospectively validated, not prospectively validated. So yes, you put, and these are advantageous, I value them, but I just don't wager on them, should I say. For example, when you look at the data, and I could actually take you through that at some other stage. It's not that if you had a score of a 4, that you would invariably falter without the use of atherectomy or without the use of IVL. You have greater chances, only greater chances of having lower MSAs. But those were data, not in the realms of OPN. They were data in which OPN was not used, in which ultra-high pressure balloons weren't used. Non-compliant balloons were used, but these were not prospective. So there was no attempt to go beyond a particular point and get an optimal result, even angiographically. So we must understand the limitations of any retrospective analysis and the retrospective validations, but still valuable, important issues that we can actually discuss subsequently. So I do follow this, but not blindly. Here's my real-world algorithm. And this is, again, I want to emphasize this because this is real-world algorithm for India. Let's not follow the real-world algorithms of the West because we have limitations of devices, equipments, costs, and expertise, and many centers. For mild to moderate calcification, for me, there's no reason to use imaging upfront. You actually just go in with a non-compliant balloon, a quarter size less, bang it in, go up to 16 to 20 atmospheres. You'll break the lesion, the tightest points, and you won't dissect the vessels. But if you can't break the lesion, if the lesion opens, you just stent it. Always stent it by having a step up and a step down. Always make sure that the area you stented looks bigger than the rest of the vessel. That's your IVUS right here in your eyes. The moment it looks right, beautiful, the moment it looks optimal, the moment it looks neat and clean, believe you me, it's undersized. It has to look larger than the rest of the vessel. That's the first step. And of course, if you can't open it at 20 atmospheres, go to intravascular imaging. Then you decide what the vessel size is. Then you decide what the lesion is like. Then you actually decide whether you want to atherectomize it. And here's the sequence I follow. If it's vessel less than 2.75, and I do this for severely calcified lesions, vessel 2.75 and less is going to be rotational atherectomy. Vessels 3 or greater, 3.5 and 4, it's going to be IVL. Rarely, if it's eccentric lesion, if it's heavily calcified eccentric lesions, where I know on my imaging that the guide wire bias is towards that eccentricity, or it's a nodular calcification with the guide wire bias towards that nodule, then I would go for a rototripsy. So that I made myself clear. Calcified lesions, severely calcified, upfront intravascular imaging if the balloon crosses, and then decide on the basis of what I said. Of course, if it's a heavy score, I would actually go for IVL in larger vessels. I'd go for rota in smaller vessels. If it's any lesser score, I just go with a non-compliant balloon, occasionally an OPN balloon up front. The advantage of intravascular imaging is not just deciding on the lesion, it decides the vessel for you. And I'll show you cases that it actually therefore relies on your OPN balloon as the first line non-compliant or ultra high pressure balloon to be able to be safe. Even if you take an OPN, you can actually take the optimal size balloon and go to high pressures instead of quarter size less balloon. Of course, if you can't cross it, then you have the rotor, and I can take you through some other day through advanced algorithms. What if the rotor doesn't cross? What do you do next? Use rotor, cross the rotor, do intravascular imaging, make sure there are no nodules, make sure that you actually understand the vessel size, the type of calcium, and then deal with it accordingly. Now I did finally, there are only two imagings that I would do. I would do an intravascular imaging up front, I would do it finally. When you use atherectomy devices, there's no point of using imaging in between. It gives good pictures, but has never been correlated with outcomes. For balloons, just plain balloons, cracks and fissures have been correlated with stent expansion and outcomes. For IVLs and atherectomies, cracks and fissures have not been correlated with outcomes. And therefore, I don't do imaging. I do upfront imaging. If I want good pictures to show you in a lecture, I would do in-between imaging, and finally, I would do final imaging anyway. Now, I want to give you some tips about rotational atherectomy, not the usual stuff. I'm here to tell you beyond what everybody knows as usual. And therefore, here's is around, say, rotational atherectomy. This is an 84-year-old unstable angina at another center, put an IABP support, continues to have recurrent chest pain, is on inotropes, he's got chronic obstructive aortic disease, he's got chronic kidney disease. He's transferred to me for a high-risk supported high-risk PCI. It's a supported PCI. You can actually see that I put an impeller in. And then if you want to see the vessel, what it looks like, it's horrendous. That's his vessel. And that's heavily calcified, tortuous LED with a large branch which comes off it. There is no circumflex. That intermedius is the only vessel that he has. RC is occluded. It's actually pretty much tortuous to 360 degrees and curved in multiple ways. It's a helix structure. And this is practically impossible to actually cross through a rotor, even with a 1.25 burr. Nothing happens, nothing goes through. So this is not even a case where you talk about IVL. It'd be ideal if something goes through, but even a rotational atherectomy of 7 minutes burr time doesn't go through. So what is the algorithm if this burr doesn't go through? That's important to understand the algorithm beyond this. So here's the algorithm beyond if the rotor burr doesn't cross. The wire has crossed, but the burr doesn't cross. You can actually firstly change to a new burr. Your burr may be getting bald because of debris getting stuck into it. But beyond 5 to 7 minutes, I would change my burr. I could change the wire, but in this case, I wasn't going to change the wire. You can go to a rotor support wire, but I think it's a bad idea. You can upsize the burr. And by the way, that's a very important thing to understand. If your 1.25 burr doesn't cross, your 1.5 could cross on occasions because of the larger burring area that it has. Yes, you can do granuloplasty. The same thing as you do in CTOs, burst small balloons to create more space. NC balloon won't cross, so it's not. Laser is another idea. Laser could actually get you a bit more purchase for your burr. Just even a couple more millimeters into that lesion, your burr would be more coaxial into that lesion, would start burring rather than hitting a rock up front in its eccentric path through that very tortuous anatomy. But there's a halfway rotational atherectomy, which I use fairly regularly in very highly calcified angulated lesions. And that's how this is supposed to be. You don't need to burr every lesion through and through. Even if you do halfway burring through lesions, you can actually fracture the rest with balloons. You can actually get IVL down and fracture the rest with IVL. So we need to understand that we're not here to treat techniques to lesions with one technology. And a halfway rotational atherectomy is something I use very regularly, where I go till a place at an angle where I believe that it is safe enough for the burr to go, and then actually come back in this situation, burr till here, and then come back, that's the burr, come back, get a balloon across, fracture all that, and soon you'll realize that everything breaks up because you actually broken the plates very early on. Anyway, in this 10 minutes of burr time, okay, this was granuloplasty was done 1.1 and 1.2 and 0.5 balloons were burst into the lesion, followed by a change of burr, followed by 10 minutes more of a burr time with a 1.25 burr, which finally then crossed. And then this was followed by a 1.75 burr. That took another 5 minutes of a burn time to cross that heavily tortuous anatomy. That was followed by multiple stenting and got a good result. What are the tips around ultra high pressure balloons? We must realize that what they do grow in size. And if I show you this, what it is that the 35 to 40 atmospheres, which I normally take these balloons up to, beyond a 25 atmospheres, I would gradually go up with these balloons, give them time to exert their pressure and gradually go up, and then maintain it beyond a 30. I would start maintaining it at 30 or 32 for a bit more duration of time, 20 to 25, go up to 35 then, and then gradually go up to 37 and then go up to 40, each time maintaining it for a longer period of time. If I go to deflate it, I deflate it and go up again. But I just want you to understand this compliance chart. This at 30 is doing what a non-compliant balloon would do at 25. So it's not much different in terms of its expansion. What it does is certainly go up to much higher pressures, which are non-compliant. Its rated burst pressure is higher. So it does grow in size. And I want you to understand that. It will go at least 0.3 millimeters in size when it goes up from 35 to 40. And that's perhaps a little less than what a non-compliant balloon would do at 30 atmospheres. So keep that in mind. So focus force, smaller balloons going up, but still understanding. So if I knew the vessel size, I would actually, if I was doing it within a stent, I would go up with an optimal size balloon and go up to high pressures. If I was doing it without a stent, I may actually just err on the side of a quarter size, of a half size less, and then go up to 40 atmospheres in that lesion. A bit of tips around intravascular lithotripsy from my editorial comment 6 months ago in the catheterization cardiovascular intervention. I want you to understand that we need to talk about balloon to artery ratio 1:1, but when we actually match it to distal vessel, we're never going to be 1:1 for the proximal vessel in a longish lesion. You know that. But I also want you to understand that you can inflate that balloon to any, its nominal size is at 6 atmospheres. That's the reason why we say it's a 3 millimeter balloon is 2.9 at 4 atmospheres, 6 millimeters at, it's 3 millimeters at 6 atmospheres. It's only 3.1 at 10 atmospheres. But the reason we're not going to actually fire at 10 atmospheres with a balloon at 10 atmospheres is that the previous balloons were thin-walled and therefore had a higher chances of rupturing and leaking if you fired it at higher pressures. Well, the present balloons are thicker walled. And therefore, you want to actually fire at 6 atmospheres, there's no problem, you're optimal size to the vessel. You want to fire at 7 atmospheres, there's no problem. But do not force it across the lesion. Always fire, create a space for this. I don't mind dilating my lesions from 2 to 2.5 millimeters, even if I wanted to use an IVL in 3.5. I want the balloon to open up so that it fires not on the balloon material, but fires into the solution. Give the balloon the time to inflate and deflate, give time between cycles, give the artery time to breathe, give more cycles over eccentric and nodular calcification. And by the way, use your balloon judiciously at the most resistant lesion. And let me just tell you how. Always just check even the IVL balloon expansion in 2 views. And even if you haven't got it fully expanded in 2 views, make sure that your post-dilatation balloon does check it in 2 views. I always post-dilate after IVL. The IVL only fractures. The expansion is going to occur with your post-dilatation balloons. It's always nice to post-dilate at higher pressures in 2 views to make sure you've expanded your balloon quite completely before stent implantation, and I'll show you how this can actually affect you. We must remember that the maximum acoustic force is generated at the 2 emitters. That's 2 emitters means 2 millimeters from the proximal marker is the first emitter. Then there's a second emitter, 6 millimeters between the 2 markers, which is 4 millimeters from the end. That's the maximum force. So if you have a resistant lesion, that's where you place the emitter at the lesion. You don't place that lesion between the two emitters. And that's when you get the maximum force generated to your most resistant lesion. So emitter on the lesion rather than between the lesion. Here is an LED lesion. It looks neat and straight. I know it's heavily calcified because you see the imaging. The imaging shows greater than 270-degree arc of calcium. It is deep. It is greater than 1 millimeter in depth. For me, this was clearly IVL and a simple IVL. So actually, I do the IVL and at 40 pulses delivered, it gave it in 20 pulses. That was very nicely done. And I'm therefore very happy. You can see that my IVL balloon is on 4th cycle, completely expanded. So I took away the IVL balloon and said, no more IVL. And therefore, I just looked at it with OCT. I saw fractures, as you can see here, great fractures. So I went ahead, implanted a stent in this cranial view, 2.75 into 18, optimized to a 3, looks great. I mean, that's the final result. All of you would say, simple lesion, well done, great IVL result, nothing more, it's expanded completely. Look at it in other view, and I look at it only because I wanted to make sure our post-dilatation was matched to the proximal edge. I suddenly see it's underdilated in the LA projection. You see this eccentric heavy calcium. I'd fractured that. I was looking at it in the epicranial, look at it in the RA quadrant. Now I have 3 millimeter at 26 atmospheres. It doesn't give way. I have 4 remaining pulses of IVL. I deliver those 4 remaining pulses. It still doesn't give way. I do an OCT. I understand that I'm clearly 3.82 MSA. That's unacceptable. Less than 5 millimeters, unacceptable for me on OCT. It's a proximal LAD. And look at it. It was eccentric. And I have to go up with an OPN at 40 atmospheres. A 3 millimeter OPN, 40 atmospheres. What am I getting? Still residual stenosis, but I've expanded the vessel elliptically, and you will see that it's a great result. It's still not the best in the RA caudal, but better in the epicranial. And now I've got a 5.16 area in the elliptical 1.6 area. Area matters, ellipticity doesn't, and I'm satisfied. So we must understand why we're using these devices, because safety is far more important. Sizing, for me, was far more important in this sort of situation. So I keep emphasizing this very fact. Look at it in 2 different views. Okay? I have frozen. You want me to carry on? My laptop got frozen just now. I will have to exit and then come back. But do you want me to give you one more example or a couple of more examples? Hello? Because I'm going to stop share if you don't mind.
Yeah, so I think Ziad Ali is joining, as he has some OPD,
Okay.
is joining on time by 8:05. We need to go
Sure.
back to the live cases again. So
Okay.
be around
And
with us for the
we
live
could-
cases. We need your guidance for the live cases, how it got completed. One was a rota
Okay.
case, the other one was a CTO. So be with us.
Sure.
So
I will. I'll
it
be
was
with
a
you.
very exhaustive and a very extensive lecture on calcium management with all the available tools ranging from IVL to high pressure balloon to ROTA and whatnot. So just quickly, one question. You launched the new ROTA Pro Plus recently at Delhi. Just tell us, for
Absolutely.
the benefit of the chair as well as for the people in the floor, how it differs. Is it going to make our life easier? Just tell us.
So for those of you who actually already are experienced at the previous rotational atherectomy, remember it's coming at a cost. And if it wasn't coming at a cost, I would say it'll make life easier for all. But for certainly those who are starting afresh, it's clearly a much easier life. But I'm not sure if it's easier life at that cost. Yes, it's very difficult for youngsters to actually now coordinate the foot pedal, the fluoro, the cines, as well as the movement of the hands. Not for anybody who's been experienced with it. So yes, I don't think for the cost sake, I would change over to a RotaPro, but it's intuitively much simpler. It's much easier. It's everything in your hand. And it's so easy to perform it with your hand because there are not many movements to do. Your foot is left for fluoro as well as cine, which is very good. So it's a great step forward, but I'm not sure for Asian subcontinent, that cost, which doesn't deliver any better outcomes, and the technique remains the same, is it really worth it? Okay?
That's understandable, sir. With your permission, we will quickly move on to Lab A, that is St. Joseph Hospital, where Dr. Damodaran along with Dr. Anand did a ROTA. We could able to see in the initial 15 minutes. Oh, sorry.
Davidson.
Deepak Davidson and Anand, we could see in the initial 15 minutes of calcium preparation with the Rota 1.5 bar.
Osteum.
Dr. Deepak, Dr. Ashok Seth is here.
Oh, yes. Yeah. Sir, good evening, sir.
Hello, good evening. Good evening, Deepak.
Sir, we learned a lot of things regarding rotablation from you as well as Matthew Samuel, sir, over the last couple of decades, and we too have started doing these rota cases live. Can you come back to the images? Come to slide sorter.
Just a comment, 30 years of, it's the 30th anniversary of our experience with rotational atherectomy.
Oh, that's fantastic.
28 years ago, I was still doing 250 rotational atherectomies a year.
Yes, sir. Great to hear that. Sir, that's the proximal LED calcification, and the vessel angiographically was looking 2.75. The lesion was extending into the left main with bifurcation around 40-50% narrowing with calcium extending into the left main. So we decided on upfront rotablation. Next image. We started with it, next, show the rotablation images. We started with a 1.5 millimeter burr at 180,000 RPM. Next, that's the initial pecking, it didn't cross at 15 seconds, it didn't cross at 180,000 RPM. Next run, we were able to cut the lesion. It crossed the lesion. Next. Subsequently, these are the images. Next. Okay, that was the image following nitroglycerin. Then subsequently we took an OCT imaging. Next run. Next. Okay, we rewired and did an OCT run. So can you enlarge the OCT image? Okay, can you see the OCT image there?
Yes, Deepak, please.
Okay, so I'll go most distally. The LED had calcification in the proximal portion. In the distal portion, there appeared to be a soft plaque based on angiography, and that's the most distal vessel. It was looking almost 2.75, 2.67 beyond that particular area. And at the site of that soft lesion, you could see that on OCT we were able to make out more of fibrolipidic plaque. There was no significant calcification over there. And then there were area wherein we could see all the three layers. You could see that these are the area wherein we could see the three-layered vessel. As we came more and more proximally, you could see that there is significant amount of fibrolipidic areas. And as you could also see here at 6 o'clock position, there is some calcium crystal, macrophages, and as we come more and more proximally, you could see the area again fibrofatty, more of fibrotic lesion, and this is the area where we saw this significant amount of calcification. You could see that at probably at 3 o'clock position there was a calcific nodule, and you could see that the catheter is lying close to that particular area. Probably it has shaved off little bit of calcium from that particular area. It looks as if we have a catheter bias and a wire bias. You could see more clearly at this particular area that the calcium nodule has been shaved off. As we come further more proximally, we made out that there was no significant 360-degree arc of calcification. There were islands of calcification, there were areas of nodular calcium, and we were able to, you could also see here that from 9 o'clock to almost, this is around 270-degree arc of calcification, and as we came more and more proximally, that's the amount of calcium we saw. So that's coming back into the left main. Left main is also significantly, diseased and calcification present. With,
Deepak,
the
as you come more proximally, don't you think it is more concentric and deep? What Dr. Ashok said?
Yes. That's what we saw in the angio also. It was looking more of concentric and it was more of deep calcification. In the junction between the proximal and mid LED, we saw that it was more of subintimal. That's what we made out in OCT also. So because there was no 360-degree arc of calcification, we thought that we'll try dilating with a 2.5 and 3 millimeters balloon, and we were able to do the dilatation with 3 as well as 2.5 as well as 3 millimeter non-compliant balloon, and it easily opened up at 12, 14, 16 atmospheres, and subsequently our plan was to stent. Now can you go on to the fluoro monitor, show us the stenting images. We decided that we'll go distally with a 2.75 stent. That's the OCT run. Next. Dilatation, next, make it fast, show us the stent. Okay, that's the initial stent being positioned. That's a 2.75 into, because we made out in OCT that the distal vessel was 2.67, 2.75. So we chose a 2.75 millimeter stent. That's a 38 millimeter stent, and that's the positioning. It's deployed at 12 atmospheres, and subsequently we pull back the balloon next, and further went up to 16, 18 atmospheres. Next, we further decided on the length based on length of the second stent based on the measurement between the markers of this one, that was 33 millimeter. So next we took a 3.5, we wired the circumflex before sending the left main into the LAD. We took a 3.5 into 33 expedition from the left main ostium into LAD. Next one. We made out that proximal LED was around 3.3, 3.25, and the left main was 4 plus. So we decided that if you have to go with a 4.5 millimeter dilatation in the left main, we need to at least have a 3.5 stent inside the LED. LED was not looking, proximal LED was not looking 3.5. We had a debate, we all had a discussion inside the cath lab whether we should go with a 3 millimeter stent or a 3.5 millimeter stent, but somehow we decided on a 3.5 millimeter stent. We decided that we deploy it at very low pressures. We finally deployed that. That's the stent being deployed. We just stopped when the stent opened up, so that was around 10 to 12 atmospheres. Next one, and we took out the balloon and made out that there was no significant carina shift into the circumflex branch, and that's where we are. Now our plan is to go post dilate with a pot 4.5 millimeter balloon in the left main, then a 3.5 in proximal LED and 3 in the mid LED, and subsequently have an optimization with OCT run. That's what we have decided to do. This is where we are. We are planning to go with the pot as well as further post dilatations.
That's perfect, Deepak. I think Dr. Seth Selvarani or all the chair is listening. And
Sir, I have one question. Sir,
yes,
are you
madam,
able
please go
to hear
ahead.
me?
Yes, ma'am.
Yes, sir. Actually, that 2.75 stent deployed in the district, no? And the stent balloon used for the dilatation of the proximal that in the left main, how much you went with the ATM?
Ma'am,
how much you are best?
It's an expedition stent. We went up to 16, 18 atmospheres in the proximal portion just to make sure that the vessel is also opening up very well.
Yeah, that's a message out of that.
Okay.
Stent balloon proximally pulled when he inflated. There was no dog boning.
Yes, sir.
There is no residual
Yes, sir, dog boning.
impediment from the calcium, so that additional tools were not required. That's why he was very confident about taking the additional stent and go up. Otherwise, for such a imaging of deep-seated and thick calcium, if that balloon dilatation of stent balloon would have not opened well, he could have definitely should have gone for some other preparatory tool. How you would have approached Dr. Seth, please?
No, so I think you've done a great job. What was the burst size that you were using?
It was 1.5 burst, sir.
1.5 bar.
1.5.
1.5.
Yes,
and
sir.
you said that it wasn't crossing beyond a particular point. I thought that's what you said.
Yes,
Or
sir.
you-
During the first run of 15 seconds, we were not able to cross that particular area wherein we
Okay.
saw the maximum amount of calcification on fluoroscopy.
But after that, you just went across it fine,
Yes,
isn't
sir.
it?
Yes, sir.
Okay.
We didn't have to increase the rotor speed.
Sure. No, I think you've done it well. I think that's a 1.5 burr. That's all that's needed for what you did. You actually saw it on the imaging. I totally agreed with you that you did the proximal balloon dilatation of the proximal vessel and tested it out with the balloon. I didn't think there was a need for any other adjunctive device. The only adjunctive device I like for osteas is a cutting balloon. If the osteas are badly stenosed of the LAD, and I would then urge, I prefer scoring or cutting balloons if I'm not using atherectomy. And finally, you're doing the right thing. I'm not so worried about the 3.5 in a proximal LED, by the way. That's the stent you would choose. It'll go up to a 4.7 max in the left main. But that's how I would do it. Fine, absolutely good.
Perfect, sir. As Deepak and Anand, as you continue to work on this case to further optimize the results, we'll just quickly move on to Government Raja Hospital. But at the same time, we may not be coming back to you.
Yeah, thank
Yeah,
you. Thank
we
you so
thank
much.
Dr. Deepak, Anand, and the entire Can you just show a minute the lab?
Yeah, thank you so much for having us
The,
here.
the only thing, I know that you after the you want to make sure that you want to remove that circumflex wire or rewire the circumflex. If you've done a pot, you are actually got a long left main there, which you're going to trap your wire in. When you take it out, you're going to shove it. The guide will get dragged in. So I actually I just do a gentle pot and then just push my next wire in, go into the circumflex, and then do whatever I want.
Yes, sir. That's what we are planning to do, sir.
Okay.
Yes.
Thank you.
As Anand, you can conclude from your lab. Thanks to all the people. Please go ahead.
Yeah. Thank you, sir. Thank you all for this opportunity. We've been very delighted to present this case from our hospital. I thank Deepak Davidson, sir, about team, and Boston for Rota, and all the support, and yourself, and all the panel members. And we'll be joining you on Sunday, sir, tomorrow and Sunday.
Please.
Thank you all for having us.
Thank you so much. Thank you, Deepak. Thank you, Anand.
Thank you, thank you.
Thank you. So we'll quickly move on to Government Raja Hospital, Madurai, where we can see Damodaran with his team working on that CTO.
Okay. Hi, Siva. I'm back again.
Yes, please. Go ahead.
Yeah.
Tell us what you did.
Can you show me? Yeah. Show me the first.
The panel is continuing. Dr. Seth, Silvarani, myself, Ganesan,
So this is
Madhavan and Karupaya.
Okay. This is where we have left you, that we have kept the microcatheter inside the body of the CTO. You can see I have exchanged the Confianza with the Gaia 2 wire. The Gaia 2 wire has progressed, but one can see it is subintimal. One can see from the retrograde collaterals through the big septal. Adjacent to that, the Gaia 2 wire was there in the subintimal position. So then now I need to de-escalate and find a way into the true lumen as a re-entry process. So what I did, if you go with the stiff wire again, it will dissect the subintima further down. So I just put a softer wire, that is filter XT, or show me the next one.
Filter XT.
And make it confirm that filter XTR went into the septal, that is showing that we are in the true lumen. Then pull back the filter XTR and redirected the wire into the false lumen. But this time it went into the diagonal. It is not in the LAD. So then we have again advanced the microcatheter and pushed the wire, filter XT wire in such a way it went into the next. Went into the LAD. And then I advanced the microcatheter to the distal LAD. Show me the next. Next. So there is no need to do a check angio, but still I just want to demonstrate that we are in the true lumen. You can see that we are in the true lumen. Next. So then we exchanged with the BMW wire, and we are going to work further on that with a 1.5 millimeter wire balloon. So I think once we cross the lesion, almost 80% of the job is over. So then we want to dilate it and put a stent, and we will optimize with the imaging. Finally, this is what we are going to do. Thank you. In the meantime, what happened, because we are not able to do the ACT here, there was some clot, so we have to exchange the catheter with the help of a dock extension with the new catheter. And though the patient was on 10,000 heparin, frequent monitoring was not possible with the ACT. So there was some clot when I just opened the Y connector. So for the sake of safety, I am just going to change the guiding catheter with the help of a dock extension. Thank you. We will work on it, and then we'll come back to you after some time.
Thank you, Dr. Damodaran.
Very nice.
We are expecting international speaker at 8:06. So
Very nice,
for
Damodaran.
now, we
Very
will
nice.
Thank you, sir.
close down, and thank you very much for your nice demonstration.
That was a great case from Damodaran. Can you just hold on to the lab for a minute? GH, Anand? Yes, Damodaran, as we are going to moving on to session 2, where we have a hub session with the international speakers coming up, we just thank you, and we want you to really appreciate your work on this very tough CTO, where you initially thought it was a recent occlusion, and immediately you realize and took a help from the dual injection from the RCA, which was really giving a lead, and you penetrated the proximal cap with the harder wire, then you down escalated, and things are happening. This is what it is in any CTO, the principles which you apply, it is going to pay off the result. So can you just, Anand, Satish, can you just conclude your session and thanking the entire team here, so that we may not be coming back to you, so we will be continuing with session 2. Please go ahead, Satish.
Yeah, it's a great opportunity for us, sir. This is the first CTO live session we are doing from the Government Institute. And we thank especially Dr. Damodaran all the way to come and teach us. We thank our colleagues, Dr. Saravanan here to support our case, our staffs, Priya and Saraswati. We have our cath technician Prakash and all our support member team here, and especially Abhat for helping us. Thank you very much. Thank you, Ananda.
Please, Damodaran and Saravanan and Satish, continue to work on the case. With this, thank you. With this, I close the session 1. I thank all the chair, Dr. Ganesan, Madhavan and Karupaya, who had a great interaction with the live cases, as well as Dr. Seth. And now I move on to session 2. I invite the chair, Dr. Selvamani, who is a chair as well as speaker. Dr. Selvamani, please. And I invite Dr. Sambat, my another colleague from Meenakshi, to share the session 2. And I invite Dr. Murugan, cardiologist. Please come to the dais, sir. So now it's not only inviting the chair for the session 2, it's my duty to invite Jimmy and Jabir, and to invite the Cochin, the unique hub, helping us to do better. That's the meaning of hub here. I could see Jabir there, and we really coined it as cracking the calcium from the Cochin. We have a tightly packed session where Dr. Ziad Ali is going to give a keynote lecture. He is tightly scheduled. We need to invite Dr. Jabir. We need to quickly, moment I hand over the session to you, we need to quickly invite Ziad Ali. Let him finish first, then subsequently we will move on to our Cochin schedule, where Jimmy, and from Madurai Hub, Dr. Selvamani, then Dr. Girish Deepak from Tirunelveli will be presenting a OCT case. Then again we'll go back to Cochin, where 2 presentations from Mahesh and R.S. Verma is going to happen. Dr. Jabir, can you just introduce the hub and invite Dr. Ziad Ali, please?
Thank you. Thank you, Shivakumar. Am I audible, Shivakumar?
Yeah. Very much audible.
Good evening to all of you.
Very much audible. Go ahead.
Yeah, greetings from the Cochin Hub. So, without wasting any time, we are going to have the international speaker over here, Dr. Ziad Ali. I don't think Dr. Ziad Ali needs any introduction to the Indian audience. He is the master of OCT. He popularized the OCT, and he stressed upon the need for optimal PCI, or rather the term precision PCI, with the use of imaging. So it's an honor and a pleasure for me to invite Dr. Ziad Ali to this meeting to deliver his keynote lecture. Dr. Ziad, please. Dr. Ziad, you are muted.
Thank you so much. So, nice picture of my baby. Okay, so what I'm going to talk to you guys about today is calcium, whether you should grind it, break it, smash it, or shift it using OCT. Ashok just gave you a very, very nice lecture. I'm describing a practical algorithm using all of the available modalities, some of which are not even available in the US. But this is going to be slightly different in really determining what the utility of the OCT is specifically for calcium and what its advantages are. So this should be fun. So the impact of calcification is that we've all experienced this, and we all know this feeling. We get the wire down, doesn't look so bad. You get the balloon or the IVUS, and then you have this happen. The wire starts bending, and you know the case just started from a 20-minute case to a 1-hour case. We also know that when you deliver equipment across this calcified lesion, it can damage the polymer quite badly. Damage to the polymer directly affects solution kinetics, and you can see what an impact it has on the stent itself. And actually, believe it or not, what's even worse than not crossing or delaminating the stent is placing an underexpanded stent into a severely calcified lesion, because then our options are quite limited. We know that moderate to severe calcium is a significant burden to long-term target vessel failure. In this analysis from our group of 13,500 patients, you see that moderate to severe calcification led to significantly worse outcomes, and this is why we included it in the Illumian 4 randomized controlled trial. Some of the fundamentals for angiography, always worthwhile describing. Moderate calcification is calcium that's seen only during cardiac motion on one side of the vessel. Severe calcification is calcium that's seen on either side of the artery without cardiac motion. And moderate to severe is calcium that's present only on both sides of the arteries during motion, but not when without cardiac motion. This is the critical experiment. 440 patients undergo angiography, OCT, and IVUS. Of those, IVUS detects 82.7% patients have calcium. OCT detects 77% of patients have calcium. It's interesting to note that the sensitivity for picking up calcium compared to the IVUS by OCT is slightly lower, and that's because IVUS is able to pick up the very deep calcium that OCT may miss, either because of the lipid on top of the calcium or in fact because of the depth of penetration. But the angiogram only picks up calcium in 40% of patients. And then what that really means is that calcium has to be the gatekeeper. Why do I say that? I say that because when you look at calcification, only severe calcification on angio is a predictor of underexpansion and a reduced minimal stent area. So the angiogram remains the gatekeeper, and this is what Ashok told us just a second ago, that angiographically guided image and calcium modification is very, very important. We define severe calcification on OCT as greater than 270 degrees and moderate as 180 to 270 degrees. But this is what I want you to focus on. We can start to detect calcium on the angiogram when the arc is more than 100 degrees, when the length is more than 4 millimeters, and when the thickness is more than 0.5 millimeter. We look at the influence of calcium on stent expansion. You'll notice that we know that when the calcium gets to greater than 0.5 millimeters in thickness, 5 millimeters in length, and 50% of the vessel arc, we're going to end up underexpanded, so we should start thinking about advanced lesion preparation. This is relevant because I showed you on the previous slide that the same factors were the ones that you can identify calcium on the angiogram. We know that this works because when we have a calcium score of 4 and we have wire bias dependent calcium modification, that this will lead to debulking of the calcium, and then a non-compliant balloon can actually fracture the calcium. When we treat these arteries, if we think about pre-PCI and we looked at patients who are calcified, we see that the calcified cohort actually does better than a non-calcified cohort. And the reason is calcified lesions do not rupture, they cause stable symptoms. Non-calcified lesions are lipidic, and the lipidic lesions can have an ACS. But as soon as we put the stents in, everything turns upside down. All-cause death increases, target lesion revascularization increases, definite stent thrombosis increases, and MACE increases. And what that really tells us is that we do a very poor job actually on stenting heavily calcified lesions. What are the goals of therapy in coronary calcium? It's to cross the lesion and modify the plaque, enable the lesion access for upscaling balloons and stents, plaque modification, debulking calcific plaque, inducing calcium fracture, and maximizing luminal gain with stent expansion. A balloon-based strategy shows non-compliant balloon, scoring, cutting, and compartmental balloons, and ultra-high pressure balloon not available in the US, but soon to be. The evidence for these strategies is relatively obscure. Cutting balloon angioplasty has a class 2B/C indication that it might reduce slippage or may be useful for osteo lesions, but it should be used routinely. Non-balloon based strategies include laser, rotational atherectomy, orbital atherectomy, or intravascular lithotripsy. And only rotational atherectomy has some mention in the guidelines reasonable for fibrotic or heavily calcified lesions. In summary, this is the mechanism of action of the different devices. An intravascular lithotripsy is going to smash the calcium. The laser is actually going to work like a jackhammer based on the fluency to break the calcium. The rota or orbital atherectomy is actually going to grind the calcium and create debris. And an NC balloon is actually trying to tear the calcium. And this is a good analogy of exactly how calcification can be considered. We know the limitations of existing technology. Balloon-based therapies have insufficient force. Atherectomy can lead to significant wire bias. Laser can lead to perforation. And finally, IVL can be problematic when we have a subtotal lesion and we're unable to cross it because it's too tight. This is the algorithmic approach that we use. We can see that the angiographic severe calcification, again, is at the top of the list. And then we use intravascular imaging to help determine what we should do next. If we have deep calcification, we use IVL, ALCO, or non-compliant. If we meet the OCT or IVUS criteria that predict underexpansion, we use high advanced lesion preparation, or we use uncrossable lesions, we use atherectomy. You should all become familiar with what a calcium fracture looks like on OCT. Here you can see it in multiple different views. You can see this signal-rich area that's highly demarcated with low attenuation is broken. And here, more subtly, you can see a small calcium fracture, again, with similar appearance. So when you have an uncrossable lesion, we like to use orbital or rotational atherectomy. When we have deep calcification, we like to use IVL or ALCA. Now, it's important to understand that when you use atherectomy and there's a layer of tissue on top of the calcification, then that layer of tissue merely impacts the tissue rather than the calcium. There's no debulking almost at all. So what you need is actually something that will penetrate through this pillow that's sitting on top of the plate. And IVL is one example of that. It can actually penetrate through. Although some impedance is lost in the neointimal thickening, it can lead to calcium fracture. Similarly, laser is also able to penetrate through the intima and actually lead to calcium fracture. So when we have superficial calcification, we need to understand that when you have an eccentric lesion, that eccentric lesion will behave in an eccentric manner. The balloon expands will lead to tearing of the artery at its thinnest point, which here is at 12 o'clock. You can see the artery is torn and the calcified nodule is completely unchanged. We know that the mechanism of atherectomy is to work in a wire bias manner by thinning out the calcium wherever the wire is and then ultimately leading to fracture. We also know that wire bias could cause problems. Here's an example of severe wire bias, and Ashoka was showing this case earlier with severe tortuosity and lots of aneurysmal disease, and this is a potential risk. You can see that you can actually end up cutting a hole in a very severe wire bias manner, and then when the balloon is inflated, you can lead to a significant perforation. When you have nodular calcium, you need to understand that the wire bias heavily impacts our decision making. Here you can see the pre-rota is sitting in the sort of 6 o'clock range, and post-rota there's almost no debulking at all in exactly the same angiographic position. This is inadequate vessel preparation. And when you take a picture, you'll actually notice why. You see that the rotational atherectomy burr is on the opposite side of the calcium. Here we use orbital atherectomy, and orbital atherectomy actually physically ends up debulking this calcification by using its mechanism of action to dig in. So in summary, angiographic severe calcification leads to stent underexpansion and is associated with high target vessel failure rates. When you have angiographic severe calcification, using this algorithmic approach can be very helpful. The device choice is dependent on intravascular imaging findings, and intravascular imaging should be studied to optimize device selection, and the calcium fracture should be identified prior to your DS deployment. Thanks very much for your time, everybody.
Thank you, Siad. Incredible. I have my panelists over here, Dr. Manu Verma and Dr. Sibi. Over to you for discussion. Dr. Siad, let me ask you a question. So, our concerns in India is the operators have two constraints. One is the financial constraints and second is the time constraint. So do you advise an imaging guided PCI for all significantly calcific lesions, or are there certain situations where you should tell, you may tell that you should not take up the case unless you have an imaging facility?
Well, that's a great question. I think Ashok's algorithm in India makes a lot of sense, okay? You can't do this on every single case, but the predictability we're starting to learn from the angiogram, okay? If you can cross a lesion and an NC balloon yields perfectly symmetrically in 2 views throughout the lesion, you have fractured the calcium, period, okay? In situations where the balloon is not behaving in a concentric manner, it's got a radial bias in either direction, that means that the calcium is not modified in one direction. And we've all been in that situation. You saw that example of where the eccentric calcium actually led to a dissection of the artery wall on the opposite side. That is the mechanism. So in situations where you've used an NC balloon and the balloon is not behaving perfectly predictably, you should use intravascular imaging in 100% of cases. The reason is you don't know what's happening inside the artery there. That would be one place. The second place would be, again, angiographically, if you don't have a perfect expansion on a calcified nodule, then you need to image it. The reason is you don't know whether that's a popcorn sitting in jello, whether it's popcorn sitting on top of glass, or whether it's a glacier. And you can't determine that unless you determine the lesion characteristics by imaging. So that is my suggestion for places that are high volume and that need really decision-making differences by intravascular imaging. Look at the behavior of the balloon and don't kid yourself. If the balloon is not perfect, it's not perfect, there's a reason.
See, may I also add that when you're faced with these severely, highly complex calcified lesions, there's no question around the fact that it adds to your safety, because you're going to end up with high pressure, non-compliant balloons or ultra high pressure balloons, which are less expensive and easily available. And their safety relies on the fact that you know what size of balloon that you're taking up at extreme high pressures. And I find that a very important aspect. I've had a couple of situations where I should have imaged because the lesion wasn't, well, there was still a residual stenosis. I didn't know the size of the vessel. I went ahead with what was slightly higher OPN balloon. I perforated the vessels, and I wish I had actually imaged it prior to going ahead with ultra high pressure balloons. So I think there's an important aspect to that as well.
Thank you, Dr. Siad, and thank you, Ashok sir. It reminds us about the editorial you have written in the Sky journal regarding the calcium. And there you have mentioned about the financial constraints and the time constraints should not prevent an operator from appropriate usage of imaging.
Zabir, there is a question from Madurai Hub, Dr.
Yeah.
Salomoni.
Yeah, but it's to Ziad. So you said that you should demonstrate fractures before you put a stent. Is just demonstrating fracture is sufficient, or do you consider some other criteria before you take a stent in a severely calcified lesion?
If I see calcium fractures, I'm going to put a stent in. So
is it,
what is unknown and is currently being investigated by us is how many fractures is optimal? Obviously, the more the better. But if you look at the IVL data, even the patients who didn't have fractures that were identifiable who were treated with IVL actually had similar minimal stent areas. So the presence of calcium fracture is enough for you to expect at least reasonable minimal stent area.
Dr. Siad, you were talking about wire bias. So by OCT, the moment you define wire bias, if it is wire bias rotational atherectomy, if there is no wire bias, is it orbital atherectomy? Is that you want to say, convey?
Can I just have, Zia, can I just have one more clarification, which I know you and I agree on? And that is that even if you don't see fractures, but you see a full balloon expansion of an optimal size balloon in 2 projections, that's good enough confidence for you to be able to implant a stent.
Yes. The mistake that people make is convincing themselves that the balloon is symmetrically expanded. And if you want to know a little trick on how to do that, is when your balloon is fully expanded, is to inject a little bit of dye. If the dye ends up biasing on one side of the balloon versus the other, the balloon is not expanding appropriately. And that's the place where you might need some ancillary NC. Obviously, if you can't cross the lesion, you have to do something. But those are the nuances between using IVL to do lesion prep and not ending up with an underexpanded stent post. Because we've all been in the situation. Oh, I guess, Ashok, one more very important thing. You have to use the appropriately sized balloon.
Yes,
right?
Absolutely.
So
for post-DIL, you have to use an appropriately sized balloon.
So
absolutely.
One of the mistakes operators make is it's a heavily calcified lesion. It's the proximal LAD. They use a 2.5 balloon. See the 2.5 balloon open, they put a stent. You can't do that. You should be pre-dilating in a heavily calcified lesion with the NC balloon that you think you're going to use for the post-dilation once you've done your 2.5. And that balloon is the one that tells you that whether or not you're going to be successful or not.
There's a question from Cochin Hub. Manu?
Following post-rota, is there any OCT findings to tell us that you require a lithotripsy in that particular patient?
I would take one step further. If you do a rotational atherectomy and then you balloon and the lesion is not prepared, the balloon does not expand symmetrically, you haven't done enough work. That's when you need rototripsy. Most often that happens in a calcified nodule or in the glacier. So you end up debulking an extremely small amount of calcium. You feel good because you wrote it and then you put the stent in. In that situation, when, again, we have to get better at using the balloon. So once we use the balloon in 2 different projections that's really symmetric, that's when you know you can place your stent.
That also happens in heavily eccentric lesions. You know, you have a chunk of a lesion sitting eccentrically. You actually may rotablate it. The guide wire pass will not get anywhere near it. You end up with a residual stenosis when you implant a stent. So the stent will expand on the opposite side and not on the same side.
If you see a 270-degree of arc of calcium, and if the thickness of the calcium is less than 5 millimeters, can you expect that the NC balloon give a cracks?
Yeah. So if you have calcium, most calcium where the minimum calcium is less than 0.5 and the arc is more than 180, it almost always breaks with an NC. But once the calcium starts to get more than 0.5 millimeter thick, the next predictor of whether you will fracture is the lumen area, okay? If you have a minimal lumen area in that site of calcium that's more than 2.5, then just like the weightlifter, when we lift weights from here, it's very hard. When you lift weights from here, it's much easier. So if you have MLA for the balloon to start expanding, then Laplace's law is applied because the amount of contact of the balloon on the artery wall allows that expansion. So as a practical approach, in a 3.5 artery or larger, you will almost always fracture the calcium with an NC balloon. Almost always. In smaller vessels, 2.5, 3.0, you're much more likely to need additional devices because of Laplace's law. You can't get the balloon big enough because it's so constrained at the beginning.
So Z, I think there's another message to convey that the lesser the arc of the calcium, the less likely the IVL is going to affect it, unless, of course, you deliver multiple and extensive pulses to that. And the greater the arc of the calcium, the better you are at a symmetrical fracture of the calcium as well as the stent expansions.
Thank you.
And
Thank you, Dr.
eccentricity.
Okay, go ahead, please.
No, I was just going to say, look, eccentricity is not a problem. necessarily, because you need calcium fractures less than eccentric lesions because you have the fibrous part of the artery. So that's the other advantage of intravascular imaging, because we often think of the maximum calcified segment, but of course the lesion is 30 millimeters, right? There's somewhere else in there that needs attention. So whenever we do lesion preparation, the lesion preparation has to be throughout the area that's going to be stented.
Thank you, Dr. Syed, for that incredible talk, great discussions. And thank you, Ashok sir, for your insightful comments.
Thank you.
I think for the interest of time, we are moving on to the next case. It's a
Great to see you, Zia. Wonderful seeing you. Always great listening to you.
So we are
New
moving on to the
ideas,
next
new
case.
concepts.
So the next case will be presented by Dr. Jimmy George. He is consultant at Lisi Hospital, Ernakulam. So he'll be presenting a case which is named as Escape from Alcatraz. I think it will remind all of us regarding the beautiful movie Escape from Alcatraz. Over to Jimmy.
Thank you, sir. Am I audible? Okay. After the talk by Dr. Syed, it's quite difficult for me to catch up with them, but I would thank Dr. Kumar for giving me an opportunity over here. I'll just go directly to, this is basically on calcium complications. I'll just go one or two cases if time permits. So, like what we're talking about, Alcatraz is somewhere in the San Francisco Bay. It's an island which is considered as a prison where you cannot escape. And the last century, many have tried crossing it, but somehow never had done it up. But in 1962, I think 3 gentlemen tried to break open this prison, and that is the story of this Alcatraz, and many of the movies we have seen after that is based on this. So these were the people wanted by the federal, the Frank Morris, the Anglin brothers who escaped. Not sure whether they're still alive or not, or they were successful in escaping, because the Federal Bureau keeps a lot of secrets, and that's the secret of the US government. So this is an 87 years old elderly female. She had presented with worsening breast angina. She got limited activities, a diabetic hypertensive with a mild CKD. She underwent an angiogram elsewhere, which was showing a densely calcified left anterior descending and as well as the left main, involving almost 90% or 95% of involving the proximal mid-LAD, the circumflex, the major OM, relatively a smaller size. And if you see in the iliocranial, almost it's a TIMI-1 flow in the LAD territory. The right coronary also has got significant calcification involving a 90% lesion in the mid-RCA. So they had attempted a right coronary PCI, but unfortunately, I think looks like the 1.5 balloon did not open up, and with repeated attempts, it was left alone for medical management. So we got a frail elderly female in her late 80s. She has got a bed sore with almost 2 weeks stay in the hospital, but still having intermittent breast angina. Bypass definitely is a good choice. The patient as well as the relatives are demanding and later pleading. So we had given the option of to the surgical side, but the surgeon is frowning considering the comorbidities what attached to it. And we are in a soup now what to do up anyway. Go ahead with the PCI or medical conservative management. Fortunately, we got some time because the pain was not that significant or not that worsening. So her bed sores healed a bit. As the surgeon was not ready, we thought we will at least give some way for the LAD territory. But she had rocks everywhere, not in the coronary. You can see the periphery also, bilaterally, a lot of calcium. The right side, we couldn't cross it up. Left side with a balloon assisted, we thought we'll keep a long sheath because of this long calcium, but that was successful. Otherwise, should have gone with the peripheral IVL down. So now we got a better look of the LAD territory. It looks quite difficult, tortuous, a lot of calcium involved, and crossing that mid-septal area seems to be almost an impossible, like breaking off the Alcatraz jail prison. So all the wires were going to the septal artery. It was not turning to the LAD tertiary with multiple attempts, almost more than 30 minutes to 60 minutes. Thought we'll just open up the proximal LAD, the 1.2, 1.5 balloon, but hardly is not giving up, but slowly giving up. Still, we are not able to enter. You cannot break in, and you need a wire to the distal LAD so that you can do a nephrectomy and cut it calcium, whatever there in the mid LAD. So multiple balloons attempted, failed. Finally, some channels opened up, and slowly we uptitrated the balloon, and the two balloons somehow gave way and opened up the mid LAD or near the septal artery. That gave us some hope. And this was a Crusade double lumen catheter with the help of a Fielder XTA, somehow channeled into the mid distal LAD. So finally, we have reached the distal LAD, but it's a long way to go. With a lot of difficulty, it was exchanged with a microcatheter, and this was followed by the rota wire, and started off burring the 1.5 rota. Took some time to burr the mid LAD, but slowly it gave way. And slowly and steadily, the burr opened up the tunnel or the microchannel or the LAD vessel. So the tunnel was ready with the multiple balloon dilatation followed by, and the stent, a long 48 millimeter, slowly but steadily crossed the lesion. So that was the prison tunnel which had opened up after repeated attempts to open it. And this was followed by a 2548 and a 328 drug-eluting stent deployed. Seems to be a decent result in the LAD tertiary. Not much was pinching on the circumflex and the OM. And this was a shot taken after that, and you can see it's not over. Got a very large perforation just proximal to the first stent or just the midway of the LAD. So balloon tamponade was done, but you can see the entire pericardial cavity filling up with dye. So though we have entered the tunnel and got out, now we got a frozen water surrounding it that we're going to drown. What they say that all the 3 inmates must have drowned and died. So what to do with this? The balloon tamponade continued. Thought we'll get the covered stent in, but the covered stent was not tracking more further. So had to get a guide extension catheter with a balloon support, trying to get the guide extension catheter in. Fortunately, the patient stood on. By the time the pericardiocentesis had been done and autotransfusion was going on. Now with a lot of difficulty, the covered stent at 2819 with the help of a guide extension catheter crossed, and it was deployed at the perforation site in a haste. But even after deploying it and dilating it well, you still see some leak. Have we missed partially? The perforation is still pouring on, and we thought we'll get the second covered stent because the balloon tamponade is not giving way. But now with the guide extension catheter, the second stent is not going further the catheter, the bend of the catheter. So we are still in a soup, and now what to do up anyway. So the balloon tamponade continued, but God was great and fortunate that it stayed on, and we sailed away, and further leaks were not there. So definitely these 3 inmates must have sailed away. This was the boat which they made with the raincoat of all the inmates available over there, and the frozen water, they must have definitely sailed away. The Federal Bureau must be wrong. I just jump to a second case and just finish off fast. Just 75 years old male, diabetic hypertensive, effort engine of fair LV function, a mid LAD long lesion with calcification in the proximal and mid area. Balloon cross, but the lesion did not open up well. We attempted with the 1.25 burr. Thought again burring it would take it up, but now have a slow flow and almost a standstill arrest. So CPR continued. Temporary pacing, all those things, and multiple inotropic supports. Slow flow, still TIMI 1 flow. took an IABP support, still is almost a standstill. The CPR continued. This was later changed to an ECMO support. Got some TIMI 1 to 2 flow. Meanwhile, the mid LED was stented, but still you can see the cardiac contractibility. Not sure whether it would benefit or not. So this was almost a TIMI 1 to TIMI 2 flow with all the circulatory supports, multiple supports. And that was the final result. But on inotrope and supports, went in for multiple arrests and could not be revived. So in this case, we could not save it up, but it's like the Alcatraz escape. These 3 inmates were well planned. You can have multiple weapons available out there to make the tunnel. They made the dummies also to hide from the jailers or the officers, and that made them success for this. So you need to have multiple tools to deal with the calcium, whether you use atherectomy either with a rotabur or you do an orbital one, you use a scoring balloon or a cutting balloon, or you use an OPN balloon or even the low pressure IVL balloon. Because prevention of complication during PCI calcified lesion is most important, and keep all the tools ready for managing complications, whether if it is slow flow, no flow, or whether it's a perforation, or whether it's a stuck burr. Teamwork always adds to it, involves the surgeons, the anesthesiologists, other cardiologists, and cath lab staff and nurse. Quite, thank you.
Thank you. Thank you, Jimmy, for the fantastic 2 cases. Real escape from the Alcatraz, and the case is open for discussion. Ashok sir, can we have a comment of yours?
My comment is that that was tremendous case. The first case, of course, the calcification, very difficult, very tortuous, absolutely amazing. Yes, that was the way to do it. Certainly the angle microcatheter. There we also have now, of course, with us angle microcatheters, which can help to get across these tight bends. Reverse wire technique is the second one, which were used reasonably often to try and get into something like that, which means that you could have actually passed it down the septal and come backwards, and it would have slipped into that LAD beyond the septum. But on the other hand, I still, what caused that perforation? Were you oversized to the vessel? What happened? I mean, that's what I could not judge. So I just had a comment. You handled it extremely well. It was very difficult to get down. You did a good job. What caused it?
I think it's that we used a 2.5 48 stent, and I think we're not over-inflated it. Even the second stent also, and the overlapping segment also, we didn't post-dilate. We thought we'll take a smaller balloon, but somehow I think it just gave way.
So you felt that the 2.5 was larger for that vessel, because it's usually, so the commonest reasons for perforation is either you actually have a rotor burr so guide wire biased in a manner that it's actually thinned out and grooved that area, so that your vessel gets weak even with a 2.5, which was optimal size, or you actually have a compliant stent which has got a compliant balloon, and therefore you expand it even to 14, 16 atmospheres, and it will perforate the vessel. It's one of those, and that's what I always believe, that you always, if you are taking a long stent and you're unsure of the vessel sizing, you always just deploy it at low pressures and then work within the stent and understand the vessel far more. You didn't use imaging at any stage. Perhaps that could have helped to avoid perforations. But then I think it's always great to be retrospective about these things. I do believe that imaging helps us for the safety as well as sizing to avoid perforations in heavily calcified vessels.
Manu?
What is the deployment pressure?
In the second case, there was a no reflow, or how did the patient become sick? You did rota, then there was no flow, and then patient arrested. Was that scenario? What happened?
Yeah, it's basically a slow flow, no flow, which could not be revived anyway at all.
Yeah,
So
we
we're
do
giving-
come across such no flows post rota. And how do you really prevent it, sir? Because we have also experienced it. And many times the patient come up but we have lost few cases also. How do you prevent and how do you select that patients that how do you avoid the no flow phenomenon?
Dr.
So-
Salmani, in fact, this is one situation which is still puzzling us. This is only one case we lost during Rota where we developed a severe slow flow. And the unfortunate thing is, you can see that vessel, the lesion was beyond the major diagonal. Had we not done that, also the patient would have survived. So it was a very painful and a traumatic thing for us. We could not revive the patient. We still do not know how did it happen. Not only that slow flow occurred in the LAD, the slow flow occurred in the LAD as well as in the circumflex. We do not know whether it is something like a systemic response, inflammatory response, or what. We are not able to make out what it is. Ashok sir, could you?
Yeah, sure. I know. I was just looking at the same fact that you didn't have the slow flow in the LAD, but you actually had a slow flow also in the circumflex, and that's what was the catastrophe. Now, can you just tell me the sequence? I've lost the history part, but the history was that an ACS situation? Did the patient present with high drops? These are things when we think that these are calcified vessels, but I've had slow flows in the vessel I'm rotablating, not necessarily related to the fact that it's calcium, but related to the fact that there's an element of ACS. In a long diffuse disease segment, you would have soft plaques, you could have thrombus, and you could have slow flow down the same vessel despite your best efforts.
It was effort angina only. On the day prior to this procedure, we thought it's a easy procedure, it's a middle AD lesion. So we tried to cross it with a balloon. The balloons, not even 1 millimeter balloon was not crossing. So we postponed the procedure to the next day.
Got it.
So it was effort angina. Then the only thought that crossed our mind is we used a 1.5 millimeter burr. So was the burr to a bigger size for the smaller vessel beyond the middle AD? I don't know.
Not necessarily. But I think, one of the great things that I always do is that I don't use it in the flush, but I give diltiazem and nitro prior to my burring all the time. It's a very good idea to do that. It actually decreases your chances of slow flow. It's like pre-treatment, and that's a good move.
Is it?
I don't find it's for slow flows for me is extremely rare unless I've misjudged a lesion and there's been an ACS.
So is it intracoronary you give, sir, or how do you?
Intracoronary, which means into the guide catheter because the vessels at that stage is flowing.
And maybe giving some time between the subsequent rota for the vessel to recover because you are giving thermal energy there.
It was not a long cut also. The rota burr could easily cross. Hardly, maybe hardly a minute or so, some 2 or 3 runs of rota.
Yeah, but it's a very odd phenomenon that you actually had. A global slow flow is a very odd phenomenon.
Yeah, there's one question from Dr. Karupaya here. You can go ahead, sir.
Thank you. Just regarding the first case, 87-year-old, heavily calcified vessel, he was skillfully pre-dilated the lesion very well without any dissection. Should have got away with just a drug-coated balloon instead of stenting. Just my doubt. Instead of stenting, we should have used drug-coated balloon alone. Because there was no dissection, you have skillfully dilated the prepared the lesion very well without any dissection. Should have used just drug-coated balloon instead of stenting.
Instead of putting a stent,
Yeah.
whether a drug-coated balloon was enough.
Yeah.
I don't think so, sir. In the sense, it was almost like more than a 2.5 vessel. And I don't think the stenting must have caused the perforation. Like what Ashok sir was saying, it is pre-stenting, a pre-dilatation must have given way from the area where the calcium was not there. And that area must have given a perforation. But drug-coated balloon also couldn't have made any difference, isn't it?
We had rota, actually rota was introduced even before the stents. We used to have rota. I think Ashok sir may be the best person to comment on it.
Absolutely. We used it when stents weren't there. And that's why we did nearly half our cases with rotational atherectomy, more than 200 cases each year before the days of stents. So no, I think it's fair enough to actually stent those vessels. I don't think drug-coated balloon would have actually, given you a good long-term result. And this was not a vessel you wanted to come back to. So I think you did it correctly. It was just unfortunate that the sizing was not accurate enough and there were weak spots in the vessel due to guide wire biases and grooving, which finally resulted in that perforation. And you always have to be gentle with them. I always worry about using cutting balloons after rotational atherectomy, even though there's some evidence to show that they give larger lumens. But you have to size these things so well, and you've got to make sure that you just do the right thing to these vessels. I think you've got to treat them gently and never be too oversized to them.
So one question, if you would have used an imaging, could have changed the...
It could have. It could have. That's why I say, for me, imaging adds to safety. It's not just the strategy. For me, it's all the time. I keep emphasizing this again and again. It adds to safety because it helps me to size the vessel. And therefore, in calcified lesions, when I'm doing high pressure dilatations, I know that I'm not going to use a larger balloon to take it to high pressures. I'm also going to be optimally sized. And that's important.
Yeah. See, apart from that OCT, it gives you certain, we have observed certain criteria after rotablation. If you see that, for example, there is something, a tear-like thing extending into the adventitia, and it gives the character of the vessel also. In such cases, it's better you don't go with high pressures. You try to undersize or go with lower pressures that prevents perforations.
Thank you, Ashok sir, and thank you, panelists. I think we are overshooting the time, and thank you, Jimmy, for that great case of yours. We'll move on to the next session, and I think we are moving from the Cochin hub to Madurai.
Yeah.
Shiv Kumar.
Thank you, Dr. Jabir. The next talk is from Dr. Selvamani, my great friend. We all know him, so I don't think there is a need for the formal introduction. And Dr. Selvamani is going to talk about technologies in PCI.
Yeah, good evening, everybody, and then thanks for such a good meet here today evening. So nice being with you, Dr. Ashok there, Jabir, all of you, and nice discussion and learning. And today I have been requested to talk on the current trends in cardiology and probably something new which we are going to get it in the short period here. And what I thought is I will tell you something which is really what we have achieved today, and then probably go into few things, and I will be finishing it in probably less than 15 minutes to 20 minutes. So we'll look at this angiogram here. It's for your interest here. The angiogram typically looks normal, and this is an angiogram of a patient who has undergone a stent to circumflex, and after that, within 6 hours after the procedure, he had a stent thrombosis. They have done a thrombosection, and this is the check angiogram. So the angiogram literally looks normal here, and we really did not know why this patient had a stent thrombosis. So we did an imaging there. So look at this image here. Although look, the angiogram is very clear, and we just couldn't find out literally why he had a stent thrombosis. This imaging clearly shows there are all factors, like there are huge major dissections here. Look at this, such a big dissection not seen in angiogram, areas of malapposition and under expansion. So these are the multiple causes which has been there, which was treated adequately with excellent stent expansion and stenting there. And in acute coronary syndrome, I have seen that usage of imaging is not so high, but there are varied reasons for that, probably the patient condition or primary PCI or cost, everything. But today we have a consensus saying that intravascular imaging definitely facilitates the etiology of underlying ACS and helps us in treating or tailoring the therapy. And of course, OCT is a gold standard for detection of thrombus. With this, you know that in acute coronary syndrome, these are the etiology like rupture, calcified nodules, spasm, fissure, erosions. And this differentiation is very easy with OCT and probably IVUS. So based on this, we can decide our therapy too. And we have a lot of evidence today now. If patient is having just an erosion without significant lumen reduction there, they can be just managed with only medical management. Coming to ACS, apart from this, in 50% of the time you can go ahead and treat, but more than 50% of time, definitely intracoronary imaging gives you an excellent idea. And apart from that, if there is a normal coronary, today our thinking is cardiac MRI is another important tool that we should concentrate so that our patient gets excellent benefit. So these are the therapies that we already know that, but minioca or a normal coronary post-MI is a new thing we should concentrate, and probably many times it can differentiate ischemic as well as non-ischemic causes, which can many times overlap on each other. And today we should bring this into our routine protocol also with the advantages of this. So this clearly differentiates the reasons for is MI or the LV dysfunction there, and it definitely gives you LV function. It can differentiate from myocarditis, HCM, amyloid, DCM, STEMI and non-STEMI, and it's a very good tool. And probably today this should also include our protocol, and we can come to a diagnosis of so many acute myocarditis getting treated, or an MI due to due to emboli, or HCM, DCMs, or Takotsubo cardiomyopathy. And coming to the new software in OCT, the Ultron 1, it is a definite and artificial intelligence that we have today. And it's an automatic EL to EL detection system, automatic calcium thickness, arc location. Here what we do literally practically manual usage of OCT, this automatically tells us that, and it gives an automatic expansion indicator, reference area, and we have a lot of advantages in that. So when you come to the morphology in the new software here, it gives you the amount of calcium, degree of calcium, thickness of calcium, and it's very easy to decide on your therapy. And this is the arc there. And coming to vessel sizing, today we search for the EL there, but that is not needed. Automatically the machine detects the EL and it gives you the exact size here. And this longitudinal view, this shortcuts, everything, this cross-section, everything corresponds to the same level of the vessel. So that's an advantage. And coming to deployment, it's an angio registration, and it automatically you can just deploy it at that time. So that's the advantage that we have with their newer software. So look at this case. This is one case which I really, I always think cases like this, which is a severely calcified vessel and then long lesions. I remember probably 7-8 years back, all these cases, we used to send them for bypass surgery. But today what is happening is, so you can just dilate that and you can literally just do a cross section of the vessel and look into the pathology at each section. So this is the cross section of this, the point where we are getting this cross section, this white marker, and you just dissect the vessel and you know what is where. In such a long calcified lesion, you can make out the thickness of calcium, whether there is a nodule, everything. Imaging clearly tells you that, and depending on that, you can go and do a therapy. See, there was a nodule there, a thick calcium, so certain areas were specifically treated with intravascular lithotripsy. And post-lithotripsy, you can do an imaging, and many of us, we have this, how it looks like. We can see major fractures like this, and of course, you can see the lumen gain also. These are some of the very important criteria post-IVL, which we generally look, and if needed, if you are not satisfied, you can again go with one more setup of IVL so that you get excellent expansion and you demonstrate calcium fractures here before you take a stent there. And this is the final result what you get here in such a case. When you do that with adequate preparation, you can go back to the area where there was a nodule also, look for the lumen area. Although there is asymmetrical expansion, if the lumen area is good, you can accept it. And for a case which was like this, today you can produce such a result without any under expansion, with excellent expansion for the entire length of the stent. So this is the usage of newer therapies and imaging combination together. IVL probably is very useful in concentric as well as eccentric, but the 100% indication for IVL is still not evolved, but probably we have certain criteria. If it is a very thick calcium, and probably if you are not getting a good yield with a normal NC, you can go ahead with this. And these are the trials which have demonstrated Disrupt 3, Disrupt 2, benefits of IVL there. I'll show you one small example of our very interesting case here. So this patient, he was attempted angioplasty elsewhere and it could not be done there. Look at this angiogram, it looks something like a thrombus, and they treated with heparin for 2-3 days and they attempted an angioplasty there. They just couldn't dilate this lesion. So definitely it is confusing what it is. Is it a thrombus or is it a calcium? So they realized it only after they couldn't dilate with a balloon there. So what I did is I also put a wire there. We had difficulty, tried to pass a balloon, just couldn't pass a balloon there. Balloon was not crossing. So naturally the next option what we have is only to do a rotablator. So rotablation was done there, and we did the OCT after rotablation. You see here, it's a very clear here, it's a very calcific nodule which the rota has burred here, and this is also a nodule there which the rota has burred, and this is here, this is what after the rotablation we could easily move that, we could take a balloon inside, but still the balloon was not showing excellent expansion, so I had to go with an IVL there, and post IVL, so these are the IVL balloon getting done there, and before stenting, even after an IVL, all those balloons were expanded well. We did a OCT which showed that there was a good lumen gain and a lot of fractures demonstrated, then did this angioplasty stenting with excellent expansion, without under expansion, no complication. So these are some of the advantages that what we have today, combining all the important aspects of the therapy and devices available. And coming to intravascular ultrasound, there are certain puzzling things which I have seen there. And one interesting thing I will show you is, look at this case here. This case, recently around a 50 years old lady underwent angioplasty stenting, stented there. And after stenting there, what happened is, we tried to dilate with a balloon. So once you dilate here, and we went up and dilated in the proximal segment. Once you dilate proximally, you see that stenosis is, the stent is underexpanded there in the below part. And again, you come back to the lower part and you dilate, you see that there's an underexpansion in the proximal part. So this is continuously happening. You dilate down, it expands, but the proximal gets stenosed. So it is shifting stenosis within the stent there. So generally what happens, what is the reason for such a cases? See here, we dilated here proximally, and finally at the proximal dilatation, you see here there is an under expansion here distally. So the shifting lesions there. So basically when we do the intravascular ultrasound there, it's an hematoma which is concealed within the lesion there. And when you're dilating at one part, the hematoma moves to the other part. It is not yielding at all. So what I did is I could have put a cutting balloon and cut that hematoma, but I put a longer stent, dilated, and just treated with a good expansion there. And of course, the advantage of IVUS is you have a low contrast, especially patients with renal failure. This is a long lesion which was treated with low contrast therapy with IVUS co-registration, which we have here. It's very easy. With a very minimal contrast or no contrast, you can go ahead and do it with co-registration in the intravascular ultrasound too. And next important point which you should concentrate, which we are not doing, is vulnerable plaque. So although we all know that vulnerable plaque is the reason for acute coronary syndrome, and we know all those reasons for this vulnerable plaque, and today how you can detect is very, very important. And these are the future that we are looking into, that is intravascular ultrasound, OCT, NIRS, and this is near infrared spectroscopy, micro OCT, CT angio, MRI, and these are thermography and SPECT. So intravascular ultrasound will clearly tell you probably there is a chance of that is vulnerable plaque. More than that, an advantage of IVUS is you can make out whether that vessel is positively remodeled or negatively remodeled, which you may not pick up in other modalities of imaging. So that's a very important thing, and of course virtual histology will tell you the composition of the plaque. And of course near infrared spectroscopy, NIRS, is also picking up. If you look at the segment's length and the amount of lipid there, it will tell you whether it is vulnerable or not. And of course, OCT, which we have been using, is a very, very useful tool there. And when you look at the thickness of the cap, if it is less than 65 microns, you call it probably it's a vulnerable plaque there, and look for signs of inflammation like macrophages. So these are the macrophages what you are seeing there, which are bright structures with shadows behind. Definitely shows it's a vulnerable plaque. And of course, plaque lipid arc is also very important. And micro OCT is the next future that what we are having. It has a resolution up to 1 to 2 micrometers, and it can tell you the pathology inside the cell, and you can make out leukocytes and cholesterol composition exactly. And of course, CT angio also can make out the core there with 360-degree slice CT angiogram. MRI has certain limitations because of its artifact there. Thermography, if it is more than 0.5 degrees high to the referral diameter, referral area, then it indicates it's vulnerable plaque there. And of course, we have nanotechnology, microscopy and all. But very important thing is, what do we do today? Today, maximum benefit, what you can do in a vulnerable plaque is to put them on an aggressive lipid lowering therapy. That is what has proved to be very useful. And I know Patrick Series was doing a trial, putting stent in all the vulnerable plaque, which was not favorable in 2005. But today, even today, what you can do is, if you are doing an angioplasty, if you see a vulnerable plaque, probably try to include that vulnerable plaque in your length of the stent. Take a longer stent and try to deploy it so that you cover this vulnerable plaque. And more interesting today is robotic percutaneous intervention. A lot of people are talking, and they are looking into that. So what you can see is it's the robotic console, and these are the cockpit there for PDCA, and this is the sledge that what we have, and these are the consoles of control of the robotics. The problem as of today is selecting an ideal case for robotics is a problem, and which is ideal is we really not sure. And as of today, it's in a very early stages that you cannot use it in acute MI because it takes time, and single vessel PCI, severe LV dysfunction, bifurcation, CTOs, calcified angles, these are some of the limitations. But advantages like telestenting, that the operator can be sitting, for example, Ashok Seth sir can be in Delhi, and I can help him out in Madurai, and he can operate the case from Delhi. So that's a very big advantage. But the limitation is we still have to have some cardiologists inside the cath lab doing a puncture there, and then these are some of the advantages. And as of today, we cannot do robotics in many cases, which we do. And even in primary PCI, it takes longer time to set up. So it's a problem there. So with this, I think we'll go to the structural. Coming to left atrial appendage closure, Watchman device. You know, atrial fibrillation is becoming a bigger problem. After coronary artery disease, I think AF is very common in the cardiology practice. And today we have a lot of problems with anticoagulations. We have different types of closures now. Watchman device, Amplatzers, and then to name Siders and so many things. And only problem is, as of today, to whom to put it is the issues. Like it's a class 2B indication in patients with contraindication to anticoagulants in AF. And of course, transcatheter valve interventions, we have pulmonary valve, tricuspid valve, and mitral valve. In mitral valve, you have 4 types of devices. One is edge-to-edge repair, indirect annuloplasty, direct annuloplasty, and valve replacements itself. So all the 4 might be useful, and of course TAVR has picked up very well. Valve-in-valve has also picked up very well. And this is an example of one of our cases, balloon expandable TAVR at our center. And this is the next is an example of self-expanding TAVR at our center there. And since it's already time, I had certain important slides with, for example, like mechanical heart support and recent advances in heart failure. Since it is time now, I think I will stop here. And very last few, because mechanical support like whatever we do Impella as well as this ECMO which we have done in our centers, you are all familiar. One thing you should remember is new thing is something called Vortex, which is coming up, something like an Impella, which is slight modification. This is from Boston Scientific. And of course, very important development is hardwares like Guidezilla as an extension catheter example has made our work very, very easy. High pressure balloons like doubly coated balloons like OPN, new cutting balloons like Wolverine, which is trackability is excellent. And in CTOs, Nick Nano, small tiny balloons, and of course type of wires have made a great difference in our therapy. And new in rotablation is Rota Pro, which is entirely handheld device. You need not have anything in the foot. And it's a very good console where you can see directly, unlike whatever we have today. And these are some of the newer advantages. And there is the improvement in the diver shaft. And one more new thing is, there are normally today, our rota has only diamonds on one side. The next is you are getting diamonds on both the sides, so that when you remove the rotablacator also, you can burr the lesion. So this is expected next year. And of course, Perclose, which has revolutionized our percutaneous intervention, especially with TAVR and then mechanical support. It's very, very useful. We will not go through all these procedures. And coming to physiology, today, very important, which is going to come up future is FFRCT, where you can plan your procedure and decide what is going to be the outcome even before you get the procedure. And pullback pressure analysis in physiology is very important. And if there are good gradients in a patient, then you get excellent results. If there is no clear-cut gradient in a patient, pre-procedure, post-procedure results may not be so good. So that is with this physiology. And of course, dedicated bifurcation stent. We did this trial in our center with excellent results. We have done 30 cases there with almost 4 years follow-up now with good result. And drug-eluting balloon, mosaic balloon, where we have done a study with 60 patients and with good results. All these studies have been published in presented at EuroPCR. With this, I think we'll stop here. Thank you very much.
That was an exhaustive lecture. The topic is like that.
Mic is not audible.
Okay. Questions from the audience?
Chellamani, it was a very excellent lecture. And I think you have exhaustively covered all the topics actually. This is a very simple question. You have seen this lot of advances happening. Still sometimes we underdo producing underexpansion or malapposition. Sometimes we overdo producing dissections and perforations actually. What are your tips to use all this technology to optimally do a PCI actually?
See, that is what we are doing every day and every meeting. That is what we are discussing.
We have all this technology. See, we ourselves, we had one case, had a subacute stent thrombosis, unexpected. We did not know what's happening. Other fellow was doing well, went and had a complete heart block, recurrent VT, came back and stents were looking normal. We are on wrong track. And what are the tips to optimally do for the purpose of our all youngsters and seniors?
See, each lesion is different. For example, you take a calcified lesion, which today, right from Zia, the Ashok and all, Jimmy have all highlighted, and they have shown their experiences also. Each case you will have to plan. You just concentrate on that and take a decision. And of course, your prior knowledge is very, very important, and prior experience is very important. So as goes on, probably this is what is going to help. And we cannot just generalize that these are all, but each case is different. For CTO, we have a different approach. For calcium, we have acute coronary syndrome, we have different approach. Probably every day we will be improving, and then probably we will be getting better each day with newer technology.
Now we have at present a branch out areas like ACS, bifurcation, left main, calcium. We have angiogram. Regularly we do, and we have other technology like OCT, IVS and all these things. And which are the area in which we must use the imaging, which are the areas we may not, which are the areas definitely we can avoid it.
Yeah, see, actually, it's a very important thing that today, if the patient is affordable, I think you should do imaging even in a simple lesion. So the only criteria, unless there is a contraindication. For example, you select your imaging modality depending on the patient. Like for example, renal failure, you go for IVUS if you don't want to do a OCT because of the contrast, or you do contrast in the saline OCT. And if a patient is having LV dysfunction, if you cannot give fluid overload or contrast overload, go for some other modality. But I think if it is available and if the patient is affordable, you can do it even in a simple lesion. Only reason why we don't in many cases cost. Apart from that, I don't think there is any other reason you should not do an imaging.
Shalimani, what is there in the future for imaging? Do you think there are more improvisations coming in imaging after the OCT?
Yeah, definitely, sir. What is I have seen is I came across an integrated catheter, which I couldn't put it here. The company is also called Corliss or something. It is a catheter which has OCT, IVUS and FFR in the same thing. And there is another catheter which has IVUS and NIRS that we already have. There is a study presented. So this combination is the near future. And of course, micro OCT will take another 3 years to come into use. Micro OCT is, it can look into 1 to 2 micron thickness. That means today's micro OCT can look up to 10 microns. This will go up to 1 to 2 microns. So the exact precision inside the pathology of the vessel can be made out. So these are some of the newer things which is going to come in recent, probably in another 1 or 2 years. And Boston is coming up with co-registration with 60 megahertz IVUS. Today there is no co-registration for anything beyond 20 megahertz in any company in IVUS, but that is coming up. So these are some of the new things which I think will take up another 3-4 years.
So right now, imaging we use for optimizing PCI, and the future is for prevention of a problem. That is, we'll be looking more into the plaque.
So that is why I spoke a little bit more on vulnerable plaque. So future is, rather than treating, it's the prevention. So I think you should concentrate more on that. But anyhow, we have only limited evidence for benefit, except for medical management, where you have good results with only vulnerable plaque, where there is no significant stenosis. But all our therapy, especially intervention, is based on lumen area and degree of stenosis. So we still depend on that, but vulnerability, I think probably it will take some more time. And almost 10 years back, I think that the trial was, Patrick Seres did it, but it was not a positive trial. But probably we'll have to wait and see for some other things. But today what you can include is, as I already told you, if you are treating a lesion, if there is a vulnerable plaque nearby, probably try to include it in your stent. That might do something benefit for the patient.
We may be looking at the predictors of progression of lesion. That may be more important. I think there are some, especially coming up is the layered plaque, and also we may be looking at the progression. What are the predictors of the lesion progression? That may be more important for us, isn't it?
Oh yeah, definitely. See, all the lesions, what we see, it doesn't occur in one day. There have been so many events of plaque rupture, erosion, again closure, again, and then finally you get such a lesion. So if you can predict it, and there are ways they are doing it now. But anyhow, predicting future is very difficult, but as of now, immediate future, whatever I see, I thought we should discuss.
Thank you, Silva. Now we will move on to.
Do we have any questions from the audience?
There were
the Cochin Hub audience.
There were some 2-3 questions. I think we have already answered it. Time is getting up.
Yeah, thank you, Silva. Now we will move on to Dr. Girish. Lessons from OCT.
To introduce Girish, Girish has got the third integrated OCT of the India at Tirunelveli, and he has developed a new love for OCT. So let us learn from him the OCT learnings from real world coronaries. Over to Girish.
Very good evening to everyone present here. First of all, I'm delighted to present my cases here in front of this crowd, who are my masters of cardiology actually, who I have learned intervention cardiology over the period of 10 years. Whenever a patient comes doing angioplasty from Madurai, from Meenakshi Mission or Apollo Madurai or Velammal, I would like to see the CD and learn a few points from them. This is how we evolved. And with special mention here to Dr. Sivakumar sir and Salumani sir, who are my particular masters. Whenever I ask for help for any complex interventions, they are there for me always. So with this, I would like to go for today's topic, where I had two scenarios. And I would like to present here two cases where I started as a simple bifurcation case, but ended up in a complex case. And another complex coronary bifurcation case, but it ended up simple. So this is what happened. First, to go to the case one. This is a 58-year-old male diabetic hypertensive who had an antival STEMI, a late presentation. He was not lysed. Echo had mild LVH dysfunction, but he was not in CCF. The angio had a LAD diagonal bifurcation disease, which was a Medina 011, and it was planned for an elective 2-stent strategy. Here you can see the angiogram. It was a left dominant system. The LAD proximal to the lesion part, that is the before the diagonal and the major diagonal, was free of disease. So it is particularly a 011 disease. Both LAD and the diagonal had critical disease, and both were very good size vessels. The diagonal was serving the purpose of an OM, and the LAD was the anterior territory. So I couldn't ignore both. So we had to go for the planned 2-stent strategy here. And before going to that, the first mode of tackling was to do the diagonal first and then to go to the LAD. So I did an OCT here to see the lesion morphology, the length and the proximal optimal sizing to understand the lesion. And I had a good idea, and we decided to go for a stenting with a 3x33 mm into the LAD across the diagonal first and then go for the LAD. This was my strategy here. And without deviating from the basics, I did a pot with the 4.58 because as per the OCT, the E yield was around 4.7 or 4.6, and we did the pot. And further the post dilatation to the diagonal branches were done with 3x12 NC balloon, and a good expansion was achieved. And then we will go for the LAD. So what I did was, I removed the jailed wire after this, and then I had rewired the LAD. And to my surprise, after that, I did an OCT to confirm before taking in a balloon, because in this case particularly I didn't pre-dilate the LAD here, because in fear of dissection to the LAD and I might not be able to recross, I directly went to the stenting diagonal, and then we did a study across the diagonal to see whether the stent was very well optimized and any dissections were there before going into the LAD. So the stent was good enough, there was good apposition, no edge dissection, and the pot was also fairly good enough. There was good extension, though there was no gap, and I was sure I was in the good place. And in this scenario, I was very happy, and we then proceeded to take the balloon to the LAD to pre-dilate it and go for the 2-stent strategy. So this was the LAD run. But after multiple attempts, I was not able to even take a 1.25 balloon over the proximal LAD stent. And further de-escalating the problem, I had a stent deformity, and then I was sure that some of the things were going wrong in the proximal entry part. So then again, I went and reanalyzed the OCT which I had done previously to check whether my track was right. To my surprise, I found out the LAD wire had entered the just entry point, just one thread. Even though we had done a good part as per our satisfaction, all other area the wire was in the intraluminal, but only in the entry point we found out the wire was in the abluminal crossing. The first entry, the first strut had gone abluminally. So you can see that in the 1 o'clock position, that was my LAD rewired wire, which had just entered the over the next period of the next course of the LAD, it was good enough. So in my attempts to enter the balloon, you can see very well in the left corner image, there was a very well deformed strut of the, I have deformed the proximal LAD stent. So it was there started the headache, and what happened to be a simple bifurcation stent, go simple put 2-stent strategy, a tap technique, and then come out, landed a problem because now my initial stent is under deformation. So first I have to correct the deformed stent here. Using a 4.5 bigger balloon, I have recorrected, and then I used a second wire to recross, and this time it was smooth enough. and again we have went on to pre-dilate, and then finally we used 2.75 into 28 stent, and I finally had a using tap technique, using various views, because the angle was pretty between 70 to 90. I didn't think of other techniques because I had wasted a lot of time until here. And after this, the kissing balloon, as per the routine stuff, we did everything, the kissing balloon, everything was done. And finally, the optimization of the LED and the part was done, and then the final OCT was done across the LED. It was good enough. So the learning point here was, then after that, finally, to make sure my kissing and everything was good, we had a good stent expansion in the LED, and we had a good figure of 8 sign in the bifurcation area, and made sure that kissing was good. And again, the proximal, the deformed stent was well corrected. We made sure that the repart was again good enough, and then we came out. So this was the final result here. To make my point here to stress is that OCT is feasible to do in all bifurcation cases, and even stent boost is helpful, and OCT was helpful to find the complications during the bifurcation PCA. And abdominal wire cross can happen even if you do a proper prot, so be aware that don't be overconfident, and it can be avoided by even using a good oversized balloon. And in this case, OCT was helpful in identifying this. Without OCT, I would have been going for another further steps which would have been lead to disaster. So coming to the case 2, this was what started as a complex. I started this as a complex bifurcation PCA because it was a 3 vessel area, but finally we ended up with a simple provisional gel balloon technique here. To propagate the importance of gel balloon technique, I have shown this case. This case is a 42-year-old male, diabetic, hypertensive, antral end STEMI with mild LV dysfunction, not in failure. Clinic, as per terminology, he had double vessel disease. The LAD was a LAD, D1, D2, all these 3 were involved, and there was some RCA involvement as well. And I here planned for a provisional bifurcation stenting because I didn't know which one to tackle first, either the D1 or D2. So I thought whichever gets occluded, we'll go for a bifurcation stenting, and planned simple strategy for the RCA. So first I finished the RCA. It was not a difficult one. And now I will explain the angio. See, you can see here, the LED is a big one. The mouth of the LED, that is a proximal, osteoproximal LED, was a pretty big size. And after that, I had 2 diagonals and the LED. In the epicranial view, you can very well see there are 2 good sized diagonals. Both are good sized. Both are supplying a good, very well good territory. And in this step, I was not able to decide which one to save. So what I thought was directly going for a direct bifurcation strategy. I will go for a provisional strategy, and whichever gets occluded, I will go for the tackling of it. And with the help of OCT, and I thought we will decide the further steps. So this was the basic angiogram. You can see the very well angle. The D1 had a very acute angle. The D2 had a 90-degree angle. So again, I avoided both the LED and the D1. I left the D2 because the ostium was not much of disease here, and then I prelated to the LED, and I did an OCT. And in deciding the morphology, the distal LED had a EL of around 2.6 or 2.3 or something. So the stent size here was 2.75. But as such, after the morphology of the disease was studied, the proximal LED area, that is the beyond proximal to the D1, where we thought of landing a 2-stent strategy, doing a part and everything, I had not much of space, because beyond the D1, within a short area of around 3 to 4 millimeter, it became 4.5 centimeter, 4.5 millimeter EL. After that, beyond this of 6 to 8 millimeter, it became around 6 millimeter. So I didn't have any stent to go for optimal bifurcation strategy, because whatever 2.75 stent I take, I cannot achieve nearly 5.5 here. So I thought I will go for sticking to the provisional strategy here. And in this case, I had to bail out with the simple strategies. I have to save the diagonal D1 and D2 without aspirin. So I thought gel balloon strategy would be better here. And this is the OCT run across the diagonal. It also showed a significant disease involving the ostium, and the angle also was nearly 30 degree. So I couldn't ignore this diagonal. So instead of going for the direct bifurcation setting in the preset, my proximal LED was oversized, and in fear of not improper optimization or good landing zone or proper expansion of a 2.75 stent, I went for a gel balloon technique here. And this is the demonstration of the jail balloon technique here. I used a 2.75 into 38 drug-eluting stent for the LED, and I took 1.5 into 12 mm balloon to jail the diagonal. And I inflated the diagonal balloon and then deployed the LED stent. And once LED stent was properly deployed, we deflated the jail balloon and then we took out the diagonal balloon. So this is the jail balloon technique to fairly preserve the LED angle, LED diagonal bifurcation. So after this, the check shot showed a good flow in the diagonal. There was no ECG ST elevation, or the patient was asymptomatic on table. So we were happy enough, and we did a proper plot with 4 into 8 and a 4.5 into 8. And the final OCT showed in the LED showed good optimization of the no edge dissection, good optimization, and even the pot was very good, because I tried to avoid as much going into the 5.56 mm area. We finished within the 4.5 area. And we have not mentioned here there was a stent under expansion with a 3.5 and a 4, so we had to take additional 4.5 balloon here to the proper plot. So with this, we were able to preserve the flow in the diagonal D1, D2. So what started as a complex bifurcation PCI ended up within a provisional strategy, and not even that, with a simple jail balloon strategy, we ended saving both the diagonals. So jail balloon technique is feasible in preserving the side branch from the closure while doing main vessel PCI, particularly in situations you want to defer double stent strategy, that where the side branch is small in caliber or long diffuse disease. And particularly OCT was helpful in deciding me the proper size of the jail balloon, because if I oversize, I would end up in dissection and end up particularly in putting a stent here. So this is how imaging helped me in this case. And thank you, sir. Now we can open for discussion.
Fantastic, Deepak. Two cases were well done and well executed and well delivered also today. I have done jail balloon technique twice. It's very useful, particularly when the side branch is not diseased, like non-true bifurcation 110, where it's a huge supplying a very big area of myocardium. At the same time, when you predict a carinal shift, the key is you need to protrude the side branch balloon above the stent, and the side branch balloon has to be sized according to the side branch distal diameter, and need to blow up to the maximum 2 to 4 ATMs, not more than that, so that the balloon is still outside the stent. You can deflate once stent is deployed, deflate and pull it out. Then further you go on your main vessel stent. These are all the keys. It has to be sized to the distal side branch, and the balloon should protrude beyond the stent in the main vessel. That's the key. It was very properly done. It was very good. And regarding your first case also, it was just one strat which it abluminally went, and it's good that you immediately recognized, you confirmed it in stent boost, and you did a part and recrossed. It was very good. I think it's over to other chairs and the floor
Shiva?
also. Yes, Jabir,
Shiva,
please.
Shiva, I just want to ask, I'm afraid of doing this thing, but it was a fantastic demonstration, very beautiful demonstration of the benefit and the ease of using it. And he could save a very complex bifurcation procedure by just doing this jail balloon technique. So when you put a balloon, which is sized to the distal part of the side branch, and you must use a New York balloon, isn't it? No
Yeah,
doubt.
definitely. New York balloon. Only
And
if you can.
this balloon, usually people use a short balloon, which is protruding out of the side branch into the main branch. And will you expand the stent fully with some 14 atmospheres or 12 atmospheres, or you partially expand the stent and take out the balloon? Then go full expansion of the stent.
Yeah, you
How do
stent
you do
balloon,
it?
stent balloon you just nominally deploy and deflate the side branch balloon, pull it out, then now you go up. Is that right, Girish?
Yes, sir. First, we cannot go to high pressure directly, because we are deploying the main vessel stenting with the side branch inflated. And we are not going to inflate to a low pressure. We are going to the optimal pressure because we are scared of a distal dissection in the side branch. So we cannot go to the full pressure, just 2 or 3 atmosphere below the nominal. We are going to deploy it. And once we expand the main vessel stent, and we make sure that it is fully expanded in all other areas, we deflate it, and then we stake out the side branch jailed stent.
Yeah, Jabir, but there are two techniques, that is modified or the old, what Shiva was telling, modified or the old jailed balloon technique. It was basically by the Japanese and the Chinese who did this. But studies have shown that it is not definite that this is going to prevent your side branch occlusion. And there is no controlled study for that. But these are certain techniques which we follow, and we have seen that many times the side branch does not occlude. Modified one is, that is, you can have a balloon and extending into the main vessel. You need not extend it beyond the stent in the main vessel. Previously what we used to do is, we needed a long balloon, and the balloon in the side branch was supposed to be proximal to the main vessel stent. So that at that time they were scared that it might get stuck there. So that was the technique. But today you need not have it till the proximal end of the stent. If it is extending into the main vessel, that is sufficient. But all this, or there is no controlled trial, and nobody has proved it is always useful. But whenever we have used, it has been successful.
We have a published report, a published case series in the Indian Art Journal from Kerala. One of our colleague, Dr. Vinay Kumar, is doing a large number of cases of this. He has made it very much popular in this northern part of Kerala.
It was a fantastic cases, Girish, actually.
Thank you.
The first case, you know, you have predicted the abdominal wire crossing just by looking at wire course and tactile feel, actually.
We had done an
wire
OCT. We had done an OCT.
What was the tactile feel and wire course? When
it was not difficult, it was just easy. So we didn't even expect it. So we were very sure that because we did an OCT after the wire cross. Even in that OCT, we missed it during a first step because we were not particularly in search of that entry point, because in all the other areas, the wire was very well in the lumen. Yeah, and the part was very well done. So we were okay. Of course, it is a miss. That's a catch here. Even if you are sure we did a good part, you don't be carried away. That's a message here. What I am telling here. Even a single strut can be endangering the angioplasty.
Yeah, Deepak, I think the reason why you had this is, whenever we place a NC balloon or pot balloon, we are so scared because it's a bigger balloon. We will not keep it at the exact edge of the stent. So probably slightly two struts we have missed, and we have done a pot, and that's the reason where it entered. So that is the point you should remember.
Jabir, we can move on. I think it's.
Yeah, I think we can move on to that.
Please.
Thank you, Deepak.
Thank you very much.
Fantastic case.
Thanks, Deepak.
So now we move on to the next lecture. It's a keynote lecture by Dr. N.K. Mahesh. He is the Chief of Cardiology at Parimala Heart Institute. So he'll be talking on the most important topic of calcium management in 2022. The calcium is the worst enemy of all interventional cardiologists, and he'll be talking about how he is tackling the coronary calcium in 2022. Over to you, Mahesh. And may I call upon now the panelists, Dr. Nararajan, who is the Professor of Cardiology at Amrita Institute, Dr. Shafiq, he is Senior Interventional Cardiologist at Renai Medicity, and Dr. Saji Subramaniam, he is Senior Interventional Cardiologist at Samaritan Hospital. Yeah, please. Okay, Mahesh.
Yeah. Visible. Thank you, Dr. Selvamani, Dr. Shivakumar. All my hub is from Madurai, and my chairperson is from Tirunelveli. Right, sir? Nagarkoil, sorry. So I would be talking to my approach to calcium 2022 after Dr. Said's lecture. It's not a patch, but I'll do my best. So greetings from my institute. It is a small hospital in the village where Dr. Matthew Samuel was born. So that is the fame of the village. So there are three cardinal points while handling a calcified lesion. The first cardinal point is that you should prepare the coronary bed. If you haven't prepared the coronary bed, whatever else you may do, you will land up in trouble, and you will end up doing much more things than what you intend to do. The second point is prepare the coronary bed. So unless you do that, you cannot get your stent across, you cannot get your imaging across, and if you push your stent and imaging across, you're going to damage the stent, damage the polymer, damage the disc, maybe even cause a stent fracture. And the third point is also just prepare the coronary bed. If you've done that well, the rest of the things should go on smoothly. So The first is the first top says coronary angiogram. If there is mild calcification, you do a balloon pre-dilatation. Stent implantation and optimization with IVUS and OCT is strongly recommended, specifically so when you're dealing with the proximal lesions, proximal LAD, proximal circumflex, or left main. You invariably should make it a point to image, because the money you spend on imaging will be much less than the money you spent on salvaging the case immediately, or maybe 3 months, or maybe 6 months later. So if there is suboptimal balloon expansion, a choice would be of lithotripsy. So first line of offense is NC balloon, NIC nano, or OPN-NC. These are all familiar, all the things you should have in your cath lab. So first case, if I may, can you just give me 1 minute, please? I think I opened the wrong presentation. Sorry, I made 5 copies of the presentation. That is why it happened. So these are the equipments that, can I have the presentation? Yeah. These are the mandatory things that you should have in your cath lab before you start with a calcified lesion. You should have a 0.8 or 0.7 millimeter balloon, that's a NIC nano, or any of those equivalents from Terumo. You should have an NC balloon. You should have a rotablator. You should have a cutting balloon, which should be the Wolverine, ideally, because there's the most effective cutting balloon, at least an angiosculpt, which you can go at high pressure, OPN, which you can go at high pressure. Next is the repeat shockwave balloon and IVL, mandatory these times, because that's what gives you the best results. And orbital atherectomy, when and if and when you have it. And finally, laser and ELCA, although not recommended exactly as a treatment for calcium, it is known to slightly, upset the surrounding area of calcium. Maybe you get a better outcome with this. The stents and wires, BRS. Dr. Antonio Colombo says strongly that if you have a calcified vessel, BRS is not a contraindication. It is an indication, because in case there is a restenosis, for the surgeon, it is best to go through the BRS rather than going through a metal stent. You should have covered stents, as proven by Dr. Jimmy's case. You should have extra support wires, and you should have microcatheters. In addition to that, we go to the next chapter, that is imaging. Mandatory when you have proximal lesions be done. You can do CT scan, which detects a spotty calcification, which is a very good tool in paneling the PCI. Even if it's a CTO, when you cross a CTO, only then you know how much of calcium is left. But if you've done a CT scan before, it can give you an accurate identification of the calcium and localization of the calcium in the coronaries. IVUS and OCT, it's your choice what you prefer. Resolution surface detail favoring the OCT, penetration media to media sizing favoring the IVUS, fine details favoring the OCT, the bulk of the clinical data favoring the IVUS. Comparison of IVUS and OCT is versus plain angiography that's done, and there is no comparison at all. So whatever is your method of investigation, that imaging that you're comfortable with and you are financially viable with, you should go ahead with that. So if you have the coronary angiogram, mild calcification, balloon pre-dilatation, if it is dilated, you do a stent implantation, and with optimization with IVUS and OCT. Suboptimal balloon expansion, you do a lithotripsy is the way to go. So I will show you from a thing. The first line of offense in any case is an NC balloon. So whatever you can't cross with the NC balloon, you do with an OPN-NC, and then you go up with depending on what is the situation that you're landing up with. So this, if you can see carefully, this is a simple angioplasty of a not very calcified vessel. Unfortunately, the balloon wouldn't expand. So we used an OPN-NC PTC balloon, that is 315. We went up to 40 atmospheres in this. So this is a structure of a OPN-NC balloon. It's a double-layered balloon with a relatively low crossing profile. It does work wonders when you can get across. This is the post-OPN-NC. You can see that the lesion is dilated very well. And this is OCT pictures immediately after this thing. If you see, in army terms, we say it's like a grenade thrown into the vessel. It's really shattered. You can see that the massive amounts of damage has been done to the calcium and to the intima. So if you're not careful with your wire, and if you lose a wire at this stage, you are in big trouble. But OPN-NC definitely does make adequate way, and this is the post-stenting of that. You find that the lumen is adequate. A little bit of flaps are there, which has been sorted out with gentle post-dilatation subsequently. So this is the first line of defense you have. That is an NC balloon. If NC doesn't work, you go for a more powerful NC balloon, in this case the OPNNC. So you have additional help with body wire and guide extension. Guide extension is a brilliant thing which has been underutilized so far. There is one new guy in the market called Guide Pro. I find it extremely useful. So this is the second case I would like to show you of a lady, 83-year-old. You can see it's not very calcified. At the same time, it is not very smooth lesion. The LAD is diffusely diseased. So we did it with the OPNNC balloon, 3 into 9 done, post dilatation done well, and then this is a fluorosafe, not a cine. So you can see the stent is being tracked, and as it reaches the midpoint of the proximal part of the LAD, it stops. That's a dead end. So guy won't go, and guy can't be pushed any further. We have got maximum supports. We wanted to minimize the time and the contrast for different reasons. So that's when we take a guideliner. You can see that the guideliner is sitting well, and then the stent goes inside. Now it's like a mutual understanding. As soon as the stent goes inside, you can find that the guideliner can be slid easily over the stent. So it facilitates the further deployment of the stent, and then the stent gets deployed, and we get a good result. So after this is over, we go to the other side. She's got an RCA lesion. RCA lesion also pre-dilated. Post pre-dilatation, we have a good result, but again, stent wouldn't track. Again, we used guideliner. See, the advantage of this is that we save a lot of time, lot of contrast, lot of energy, and a lot of speculation as to whether it will cross or not. The guideliner crossed the thing very well, and we got a very good result. Why it was so important to do this case with minimum contrast and very fast was because A, she was 83 years old, B, she had very severe aortic stenosis, and she had to be tackled for that also. So this whole process finished off within about 45 minutes. We got a good result in the RCA. Since we got a good result in the RCA in the same setting, we could easily go and replace her aortic valve also with the percutaneous valve and come out. So this helped us to really take off the tension of having to track the things through the calcified vessels, and we eventually landed up with a very good result. So this is a simple thing. So you just use an NC balloon and you use a guideliner to push through. So when you have a moderate to severe calcification with an uncrossable lesion, that is when rotational atherectomy or orbital atherectomy, which if and when it comes to India, we'll start using. So this is a second case I'll show you of a patient who came to us with a ACS, and we found that he was, you can see the calcification from one end to the other end. So the whole LAD is calcium jacketed. We waited for a couple of days, made him settle down, and then we went ahead with rotablation of the proximal. The proximal lesion crossed very fast, but the distal lesion, we had to practically do for about 120 seconds, 120 seconds before we could actually break through and get some sort of a lesion that could be opened out. And once the rotablation was done, we decided that instead of sending from one end to the other, we'll just do a spot sending based on the OCT findings, which I will show you now. So this is the final result. So we got a reasonably good result, considering the fact that the LAD is calcified from the ostium to the tip of the LAD. We got reasonably fine result just by doing a spot sending. These are the post-rota pullback of this thing. We do as much as possible. We do imaging. We do repeat catheters, but then that is a way forward. Otherwise, we'll not be able to sleep peacefully at night. We'll be able to sleep peacefully better at night if we know that you've done a good imaging. So this is the post-rota images. I'll show you the extensive calcium, but no money for IVL. So I had to be satisfied with what I have. So we just satisfied with opening the lesion with the rotational atherectomy and dilating with an OPNNC balloon. We went up to 45 atmospheres to get these results. And this is the rota cuts. If you can see, there's very thin, shiny areas which you see in the vessel because of the rota. As we come proximally, the effect is much less. But distally, you can see that practically the whole vessel has been cleanly shaped by the rota the same. So we have post-LAD run, which is very good, and this is the final post-tending surface area. We had one area of narrowing where we could really get about 70% of area, 73% area expansion. We didn't have money for cutting balloon or for IVL, or we'd have got a better result. However, we got 5.32 distal LAD, 6.32 proximal LED, 4.75 at the tightest area, and ostial LED we got 7.19. So the areas are very satisfactory, and 6 months down the line the patient is doing very well. This has been told again and again and again. I have to just put a slide across for the fluency of my talk. So this is how you have the calcium scoring for using OCT. And this is the disposal of the lesion. When you have a deep calcium, you think of a scoring balloon, cutting balloon. When you have a superficial calcium, you think of doing a rotablation. When you have a nodular calcium or a very deep calcium with a nodular calcium, you think of an IVL. So this is a protocol which you can derive as per your liking, depending on the arc, the thickness, the length. If it is very thick and very solid calcium, you'll require NC, scoring balloon, cutting balloon. Or if it is balloon crossable easily, then you can do an intravascular lithotripsy. And invariably, as far as possible, please image, because you have to have a satisfaction at the end of the day that you've done a reasonably good job. So this is the scoring for the IVUS. IVUS doesn't go into the depth, but it tells you the arc, whether it is 360 degrees, whether it is a calcified nodule, and the vessel diameter. Again, you have scoring system based on IVUS, although OCT scoring system seems to be a little more scientific. So when you have an uncrossable lesion, we have gone with the rotational atherectomy or orbital atherectomy. Eventually, what you see is that if eventually you cannot get a good clearance, at present the Vajrayudham or the most powerful weapon we have is still an IVL. So this is the final case I would like to present. This is a 74-year-old gentleman who came to us with angina. He was moving from class 1 to class 3, and you can see that at the bifurcation, what we thought was a thrombus. So initially, when we took a shot, we found that the vessels are quite all right, and there was a thrombus there. So we waited for 48 hours on infusion to see if it will disappear. Unfortunately, after 48 hours, things remained the same, exactly the same. So then what we did was we took a 3x9 very short balloon, wired both the vessels, and did a gentle dilatation of that area. Once the dilatation of the area was done, we did an OCT. OCT was done into the LED. When OCT was done into the circ. This is how a saline OCT looks like. You can see that the OCT catheter is coming back. However, you cannot see any contrast there. It has got plus points and minus points. The biggest plus point is that you don't use contrast. So you have post OCT, we checked, nothing changed. The lesion is still there and it's still very tight. So these are the indications. These are the definite places where you should do an imaging, because you should know what exactly you're dealing with and what is the extent of what you're dealing with. So incidentally, this man had a stent in his mid-LAD, which retrospective questioning he came out with that it is done. And if you see the vessel from one end to the other end, it is practically 360 degrees of calcium, and it's coming into the left main. The proximal LAD, the LAD is fully calcified, and the calcium is very thick, more than 1 millimeter thickness, and it is extensive from one end to the other end. So this is the proximal calcium in the LAD. Then you have, I'll move fast for paucity of time. There's this you can see the middle moving picture, the amount of extent of calcium that's there. So when we come to the proximal area, it is again calcified and it's a tight lesion. And in the circumflex also, surprisingly, distal was very clean, very smooth. There's just fibrotic tissue. As we come proximally, where there's a tight lesion and the ostium, you'll find it is extensively calcified. So there is again almost 360 degrees calcium around the circumflex and around the LAD. So ostium of the circumflex is also distinctly diseased, because that decides our strategy while managing. So this is the tightest part of the circumflex. That is how it looks like, distal, mid, and this is the tightest part, extensive calcium. You can see that in this picture itself, you can see it's practically more than 300 degrees of calcium. So what do? We take a 3 into 12 IVL balloon. We first place the balloon into the circumflex, and 40 pulses were given there. And subsequent to the 40 pulses, we took an angiogram, and surprisingly, that white thing has disappeared. Now it's clean. Now it is clean, so we can be rest assured that the calcium has been cleared from that area. Then we put the same balloon back into the LAD and little bit into first 20 or 30 on the proximal LAD LMCA junction, and then a few into the stent that was already there distally. Then after that was done, the OCT was repeated. This time the OCT shows a significant cracking of the calcium. It is again not as good as, not as powerful as the OP and NC results, but you can see that the calcium has been significantly calcified, destroyed. You can see the post-IVL cuts. All these cuts show that the calcium has been damaged significantly. There is enough passage that has been made, and although Dr. Seth is of the opinion that we not necessarily do OCT after IVL, this was just done for education purposes. So final, we did a standard DK crush, and we got final results, which is very good. Now we got distal expansion of 100% and proximal expansion of 95% in the LAD. This is the area 7.09 and 12.67 in the proximal LAD. In the junction 14.6 in the RC in the left main 15. So there are two myths there, that the Indian left mains are very small. It is not. We've got 14 and 15 area in the left main. In the proximal LAD is also 10 to 12. So this summarizes the chart which I was trying to say. If you have mild calcification, balloon predilatation, stent imaging as far as possible, please, because it makes a lot of difference in your future outcomes. If it is moderate to severe calcification, there is no second thoughts about imaging. Specifically, so if you're dealing with a proximal lesion, you should image. When you can't cross the lesion with which is an uncrossable lesion, that's when our rotational atherectomy comes in. That is precisely why Dr. Seth was saying that the cost-risk benefit ratio of the newer rotational atherectomy may not be feasible because the usage is coming down significantly once IVL has come in. So, since it is from Madurai and since the chairperson is from Nagarkoil, I thought I'll just conclude my stent like this. This is the stent. What is the aim? To put the stent in the coronary. And this is the villain, the calcium. So what do we have in support? We have Nick Nano. I don't know who this actor is, but he's a Tamil actor. We have Nick Nano. We have most reliable, most dependable Katappa, who is non-compliant balloon. We have Guide Pro. This is from Nagamma, who can swallow the stents and put it across to the place. And you have OP and NC, bulky fellow. But once you can get him inside, he can do phenomenal amount of damage. And rotablation, which is basically drills the way through. And you have cutting balloon, which can cut the way through to this thing. But the boss of all this still remains IVL. You have the IVL, you can achieve what others cannot easily achieve. Thank you.
Thank you, Mahesh, sir, for this wonderful
Thank you.
Presentation.
Thank you, Mahesh.
Yes.
Extraordinary presentation. And if the stent you have shown in the last slide is the stent, we would like to do anything to get that stent. It's beautiful. So it is the topic of how to manage this calcium. So, it's the most difficult situation that interventionalists tackle every day. We need a lot of gadgets, a lot of constraints, the time constraints, the financial constraints, multiple things, increased chance of complications, and the long-term results, we may have problems. So the topic is open for discussion. Nadraj?
Thank you, Dr. Mahesh, for that dramatic, cinematic way of showing how you will defeat calcium in the year 2022, meaning that next year you'll probably even defeat it more. So I just wanted to ask you the question. One thing was very clear. If the lesion is uncrossable, you will do a preliminary rotablation to help delivery of subsequent hardware. Let us say your lesion is uncrossable, you did a rotablation, thereafter you are able to deliver devices. What will be your next strategy? Will it be Nick Nano? Will it be, not Nick Nano, will it be a high pressure non-compliant balloon? Will it be a cutting balloon? Will it be a scoring balloon? Will it be an IVL? So how do you decide on what is the next step? Uncrossable lesion, you have done rotablation, so you are able to deliver the next hardware. What will be your next approach? Can you just explain to us?
So the next approach is depending on what the patient can afford. I'll take a non-compliant.
Depending on, no, let us say that there is no financial constraint.
No financial constraints. I'll take a non-compliant balloon, dilate it a little bit and do an imaging. After the imaging, I would like to see what is the extent of calcium, what is the depth of calcium, and how bad it is. As of now, I'm a big fan of IVL because it has never let me down in any of the cases that I have gone through with it. So if I find that the calcium is very extensive and my non-compliant balloon, as Dr. Ziad Ali was trying to tell, is not able to expand the way I want it to expand, I will make space for IVL balloon, go in, do an IVL, and then do a post-NC dilatation, and then take on from there.
Which are those cases where you can probably get away with the cutting balloon without the need for an IVL? Which are those subsets of calcific lesions where you can get away with cutting balloon, avoiding an IVL? Can you explain to us?
So if you have a, depending on the calcium score in your OCT, depending on the thickness of the calcium, depending on how fibrocalcific the lesion is, these are the cases where it is predominantly fibrocalcific with a thin sheet of calcium, which I can get away with a cutting balloon. I would like to do that. Again, if you remember what Dr. Seth was trying to say, if you do a rota followed by a cutting balloon, you're going to be in some sort of a trouble because that is going to cut through the weaker sections and create problems. That is one place I would stick with a non-compliant balloon. If I have not used a rota, I have just used a non-compliant balloon, and my imaging says that it is very thin calcium, fibrocalcific lesions, I would probably go in with a cutting balloon. And ostial circumflex, again, I would like to go in with a cutting balloon.
So it is unsafe to take a cutting balloon after rotablation?
It is unsafe.
Is it?
So is it, what is the most important parameter you will take? Is it the thickness of the calcium? Is it the circumferential calcium, that is the arc of the calcium, or it's the length of the calcium?
Predominantly, IVL helps maximum in thickness of the calcium. So the thicker the calcium, the maximum effect of, there is minimal effect of the others, unless you're taking an OP and NC and hope that it breaks. So thick calcium, again, if you see the OCT scoring, if it is thick calcium, more than 270 degrees and more than 0.5 millimeters long, you should ideally get something to break that into pieces.
Before the advent of IVL, we were routinely using cutting balloon after rotablation without much of accidents. I think with every development in the technology, we always tend to become more cautious with the previous available technology. I'm sure there is enough evidence that after rotablation, it is not that very unsafe. I'm sure you yourself must have done cutting balloon inflations after rotablation.
This is what Jimmy told us in his presentation. He landed in trouble. This is what Dr. Ashok Seth had to say. This is what Dr. Ziad Ali had to say. Probably they are much more experienced in their field. I'm not a big fan of cutting balloon. I use it only when I have a fibrocalcific lesion which is not amenable to even an OP and NC balloon, or for that matter an NC balloon, or the ostium of the circumflex, which is very fibrous and very thick and the most muscular area. These are the two places where I would like to use a cutting balloon as a default measure. Otherwise, I keep it at the back of my hand. For ISRs, for for those kind of lesions, I use cutting balloon, not for calcium predominantly.
The SVG lesion or
SVG lesions.
And Dr. Mahesh, the situation where, due to the, Dr. Ashok Seth was telling, if it is a excessive wire bias, a severe wire bias and excessive cutting or excessive rota, so excessive rota producing thinning of the blood vessel, and then if you go for a cutting balloon, then you can land up in a trouble.
You never know what you have done.
Yeah. So that's where a post device, IVL as well as rota, a post device and imaging may be of immense value.
Exactly.
Especially to decide the size of the vessel. Over-dilatation, selection of an oversized balloon may be the thing that leads which lands us in trouble.
Agree, sir.
Yes.
Sir,
Saji.
Thank you for the wonderful presentation. And one more thing, sir, is there any angiographic tips by which you will straight away decide your strategy in the calcific lesions? Like if there is is it a adventitial calcium, or is there is a old way of looking at any angiographic parameters by which you decide your strategy straightforward?
whatever, if I don't see very thick calcium in the angiography, if I can get a non-compliant balloon across, that is my first strategy for almost every lesion. Only the strategy needs to be analyzed with imaging predominantly when your non-compliant lesion can't go across or can't dilate. That is when you think about when you think about imaging more than anything, something more than angiography to pick up. Incidentally, in the slides that Dr. Ziad Ali had shown, the modality that is most sensitive for calcium is still angiography. It is not IVUS or it is not OCT. So the percentage of calcium picked up on angiography is much more than the percentage of calcium picked up on OCT or IVUS. So once you have diagnosed there is calcium there, then you take a chance. It can be very deceptive whether this calcium is thick, thin, or very, very thick. That you take a normal, you have your own strategy of a normal balloon, dilate, and if it doesn't go up, then you imagine see what is going wrong, whether it requires cutting balloon or a OPNNC or an IVL.
Angiography can really deceive us, isn't it, regarding calcium? Because it can tell us there is calcium, but it cannot tell us whether it is quantify the calcium, whether it's superficial, whether it's deep calcium. And to select the appropriate strategy, angiography is an insufficient investigation.
Absolutely agreed.
So, Shafiq, you want to ask something?
So that's a very comprehensive presentation. Just for a learning part, you said that the bed preparation obviously is the first three cardinal. What would be your perfect, or how do you assess that the bed preparation is perfect? As it was mentioned before, there are fracture points. What would be the best signs that say that the bed is well prepared? And another follow-up question is, you had mentioned about scaffolds also. Probably in further surgical management is required.
So, Jabir sir,
how would you place those patients?
Yes.
What would you look at?
This is the last question from our hub.
Yeah, okay, sir. Okay.
First answer is that first answer is you take an NC balloon and 1-to-1 size the vessel, and if it is able to dilate properly, you can be safe. If you're still not confident, you have to do an imaging and find out what is it. Now, this BRS is not my concept. This is a new concept which
I fully agree with what you said. Short of imaging, if the vessel is 3.5, after your preparations, etc., if a 3.5 balloon dilates fully well in orthogonal planes, not just one view, in multiple views, if you see that the balloon has opened well, it is fair enough reason to believe that the lesion is well prepared. It is a poor man's imaging actually.
BRS is a new concept that has been put up by Dr. Antonio Colombo in the last meeting I attended with him. He's got very strong points. He's very much for BRS and tackling the smaller lesions with the drug-eluting balloon, so that your treatment can be modified much easier.
Thank you, Mahesh. It was an extraordinary talk, and we learned a lot from the discussions and from the talk. And thank you, panelists. You are going to stay back for the next session. So may I call upon Dr. Rajshekhara Verma. He's the Senior Interventional Cardiologist at Aster Medicity, Cochin. He will be presenting a case on the Mission Impossible, another calcium management. Dr. Verma.
Good evening. Thank you for inviting me and having me on this forum. This is a case of coronary calcification where rotatripsy came to the rescue. 66-year-old gentleman with diabetes, coronary artery disease since 2002. He underwent bypass surgery in 2011 with Lima to LAD and SVG to diagonal and PDA, or so we thought. He later underwent a PCI to left circumflex and RCA CTO in 2017. The RCA CTO was a reverse cart technique that we, with IVUS guidance, for occluded SVGs. That is a different story by itself. It's a long story, so we'll skip that part and come to the current admission with recurrence of angina in 2021. So after medical stabilization, he underwent a coronary angiogram. So this was the angiographic picture. There was angiographically evident significant coronary calcium in the proximal LAD. You can see that though the distal LCX stent is patent, there is significant stenosis before that. This is the epicranial view, which shows the LAD which is totally occluded, and there is a large diagonal which is also having significant disease. There appears to be a small retrograde fill from an SVG, but the proximal part of the SVG could not be imaged. This is the ileocaudal view, again shows significant calcium. You don't need any imaging to show that this calcium is very significant or very thick, and it's going to be a big problem for any interventional approach. You can also see the lesion in the circumflex, the proximal part of the circumflex. You can also see the diagonal which is with proximal stenosis. The distal part of the diagonal is patent, and the RCA which had been stented is remaining patent, no significant lesions there. This was the lemma showing good flow to the LAD. And then we had to, because of his symptoms, we had to plan the PCI. The plan was to do angioplasty from left main through the proximal LAD, calcified LAD, and the calcified diagonal into the diagonal. The distal part of the LAD is well serviced by the lemma. We also wanted to open the proximal part of the LCX. So we initially put 2 wires into both LAD and LCX, but then no hardware could be pushed. Nothing, not even the smallest balloon could pass into the LAD. So we had to modify the technique a bit, and then we had to convert the wire in the LAD to a rotor wire, and then we started with rotablation. Yeah, so after rotablation, we had reasonably good flow, and you can see some more reflex from the diagonal into the SVG graft. So after that, we had we did some balloon dilatation with a non-compliant balloon, but then that was again finding a lot of difficulty in inflating the balloon. Balloon was not expanding well, and in trying to push the balloon forward, the wire came back, and then there was a small dissection flap also. So that had to be, another wire had to be renegotiated by the side of the dissection flap into the true lumen into the diagonal. And after that, after initial dilatation with smaller sized non-compliant balloons, we took we did intravascular lithotripsy with an IVL balloon, which was 2.75 millimeter in size. We did IVL to the proximal part of the diagonal and the proximal part of the LAD, and also into the left circumflex. So I'm just showing some of the images, I'm not showing all the images. And then subsequently, stenting was done into the LCX with a balloon kept from left main to LAD. This was a mini crush because of the very large almost 90-degree angle. We didn't have to crush much. Almost like a T stenting. So further balloon dilatations were done. NC balloon dilatations were done. So this was necessary. So because even after the IVL, we didn't get full expansion of the coronary bed. So after further balloon dilatations, we could quite easily push a stent, and 2 overlapping stents were done from diagonal, and then from LMCA into LAD into the proximal part of the diagonal. Port was done, final kissing balloons were done, and then again final port was done, and this was the final result that we obtained. And to a surprise now that you can see, there's a reflux from the SVG to the diagonal, and then there has been a piggyback, another SVG which is connected, and that is actually supplying the distal PDA branch. That is also evident in this picture. So after this was the angiographic result, we unfortunately could not do imaging in this patient. On follow-up, he had an uneventful recovery. He was discharged on dual antiplatelets, beta blockers, the usual drugs, statin. It's been more than 1.5 years since the procedure. He's been on follow-up, no angina since then. So in summary, rotablation enabled entry of other hardware into the densely calcific lesion. Intravascular lithotripsy to LAD and LCX helped EC delivery, proper deployment and a good expansion of the drug-eluting stents. Combination of rotablation with lithotripsy, or rotatripsy in other words, is very useful in select indications like this. Cost is of course a big concern and might limit the use of advanced imaging techniques sometimes. Thank you.
That was a fantastic, Rashir Verma. Very challenging case, combination of both superficial and deep calcium. This is an ideal case where one can combine the very look of your angiogram clearly tells there is a dense, deeper calcium. Of course, the hardware, if it doesn't go in, then naturally you have to take the help of rota. However, you are going to upsize the burr, your deeper calcium will not be touched by even upsizing the burr. This is the scenario where K. Narajan was asking, when will you consider additional devices instead of being rota on board? So it is a cost when will be limiting, or even by upsizing the burr, it's not, moment you think it's not going to touch the deeper calcium, still after the rota, which is now allowing the next hardware to go in, but there is arc of calcium deeply seated, thick all around, then this is the case where your IVL is definitely going to help. Well done, very challenging case, and it's up to the other hub panelists to further take it up. Jabir, please.
Yes, Naraj.
As Dr. Shivkumar very rightly mentioned, this is an extraordinary case where it was nicely demonstrated by Dr. Verma that nothing could enter. The rotablation actually enabled the next entry. As Dr. Shivkumar very correctly mentioned, even the angiography, even without the need for imaging, it was extensive calcification, and that's why the IVL actually worked. This was a classic case where rotablation to enable the entry of the IVL balloon and subsequent How many IVL balloons were used in this case, Verma?
2.
2 IVL balloons. Very nice demonstration of rotational atherectomy followed by IVL.
The initial IVL balloon ruptured.
Pardon?
Initial IVL balloon ruptured.
Shivkumar, what is your experience with IVL balloons rupturing, even with the first shock pulse? How to avoid that?
Yeah, I think Ashok said put one slide, the principles of using IVL. We need to blow up. I have used some so far around my center, whole lot, all the colleagues put together. We have used around 10 IVLs so far. Of course, cost is a big limitation. We have not ruptured even a single balloon. The principles which he has put, which I listened from the IVL proponents as well as from the IVL industry is, you need to blow up the balloon up to 4 ATM. If you don't wait for that initial blowing up and if you deliver the pulses before the IVL balloon gets blown up, then you may have a tendency for rupture. Another is, but as rightly said by K. Narajan, that still taking all the precautions, still an IVL rupture, balloon can rupture. That's why the company has come up with now, they have improvised their balloon technique. They have, it is presently available balloon is very thin. They have modified. The present registry which is going on, which initiated by Ashok Seth, is with a newer upgraded balloon. I think there is some issue with an existing balloon. The IVL rupture was noted in spite of all the precautions being done. Of course, from our side, the precautions, what we can do is, we need to initially do some preparation for the IVL balloon to track smoothly. We cannot straight away challenge the IVL balloon. We need to make enough space for the IVL to get in and allow the balloon to open up for ATM, then try to deliver the pulse, allow it to cool again, then you deflate. This is the few suggestions I can do it, but my experience is very limited.
I fully agree with you. Recently, I also had a chat with the IVL balloon industry people. They also said that there is a problem with the existing balloon, and they're coming with a new version of the balloon.
Absolutely.
And they suggested that you inflate at 4 atmospheres. As the pulses are being delivered, you gradually increase it to 6 to 8 atmospheres. That's what they said, as a trick to avoid rupture of the IVL balloon. We have had some bitter experiences of 2-3 balloons rupturing in the first pulse.
Okay.
And the bed should be prepared properly.
This is a very nice point that you made out. I also believe that you should actually take a smaller balloon, create some kind of path for the IVL balloon, if necessary a rotablation. I'm reasonably certain in my mind that after a rotablation, an IVL balloon is unlikely to rupture.
The bed should be well prepared and the appropriate size of the IVL balloon. It has to snugly touch the vessel wall.
We have had 2 ruptures of IVL balloons so far in our series.
Okay.
And both those balloons were the old balloons. One was in this particular case. This was after a rotablation was done and after NC balloons were already used.
Still
yes, and so I don't blame the preparation so far as a cause for balloon rupture, and
it's an inherent issue of the balloon itself.
I think so.
We had one rupture.
Balloon, yes, that was one of the very first uses of IVL that we had. That was a rupture in a very, there was multiple dense calcium spicules would have been there, which probably caused the rupture. So,
absolutely, the spicules. See, the IVL is naturally meant for circumferential calcium, deep-seated. It is after all a balloon. We always know the balloon when there is a spicule around. That's why when rota is upfront and taken care of those spicules, naturally the IVL injury is lesser. So by imaging or by the feel, if you think there is a superficial element, particularly a spicule is sitting up, then naturally any balloon will have a tendency to rupture.
But then Dr. Verma did mention that after a rotablation and an NC balloon, still the IVL balloon ruptured, meaning it may not be due to a spicule itself. I think there was a problem in the balloon design, which they have kind of overcome.
Yeah. Probably the imaging would have clearly shown no more spicule is existing.
That's correct.
And the IVL still ruptured, then it's a clear case of the defect in the balloon.
Correct.
Of recent, because after the change in the balloon, I think ruptures are much lesser and frequent. So, hardly ever reported, I think.
Nice case, Dr. Verma. Thank you.
And the IVL has become a big hero, as Mahesh was showing it as Rajinikanth. Isn't it? It has become a big hero, and you can see it angiographically when it really cracks the calcium. The lumen increases immediately, and you can see itself. Even you can make it out from the angio itself, isn't it, Mahesh? Yeah, he's there. He has a so for him, I think IVL is the most important gadget. And any interventionist who is tackling significant calcium or very complex calcium should have rota and IVL on board, and OPN. These 3 are essential gadgets to be on board.
In fact, on some images, a balloon, an IVL balloon, which is not fully expanded. As the ultrasound pulses are being delivered, the balloon slowly expands.
Right.
That also has been seen. So that is also an indicator that the calcium is yielding.
Right. I think We are done with questions and queries from our end.
Yeah,
Over
yes,
to you, Shiv
Jabir.
Kumar.
Clear. In Madurai Hub, the mood is solidly towards liquids. So how about there in how about there in Cochin?
We have started swimming.
We have actually followed, Shivakumar, we have already followed a hybrid strategy. Liquid, solid, and then again liquid.
Yeah. The burr cannot swim across the calcium. It doesn't do the job. Similarly, the moment is swim and towards liquid, I think the time to close the session. I think let Jabir start closing the hub, then subsequently I jump in to close it. Please, Jabir, please.
Thank you. Thank you, Shivkumar. I must take this opportunity to thank our faculty who has done a wonderful job, our panelists who have discussed it well, and the international faculty and all other the members, our senior cardiologists and our young interventionists who are all present here. Thank you very much for your kind attention. Thank you.
Thanks
Over
a
to you,
lot.
Shivkumar.
Yes. Thanks a lot, Jabir. Moment I contacted Jabir and Jimmy, they were immediately came up with the great idea of cracking the calcium from Cochin, and to their word, they really stick on to how they dealt with the calcium. The great lecture from Dr. Makesh, great case by Dr. R.S. Verma, and there was a great case by Jimmy also. From Madurai Hub, Salomini did a great work on the PCI technologies, past, present, and future. Giri's shown two great cases of OCT learnings. One was malposition and abluminal wiring got corrected by a part, and another embedded balloon technique. So with this, let's close the day one. And thanks to the Cochin Hub and all the faculties and speakers. We are moving on to day two tomorrow. Please, the faculties here represented from Cochin Hub can connect to us virtually. The link will be sent to you. We have kept a day two program also very entertaining, like back-to-back live cases, keynote lectures from Ajay Kirtane, Kirti Punamia, and so on. Thank you, one and all. Enjoy the dinner over there. We also will have disperse here with the dinner. See you tomorrow virtually. Thank you, one and all.
Good night and cheers. Good night and cheers also.
Cheers. Bye-bye.